to me so, to me so. Yeah, back up, put your money now. Yeah, every cent, put your money, can see. Oh,
Sorry, right? Not my friend say so. You should wait. Mrs. Hamudino. You're not been a for. You start with you. You're not been a for. Oh, I'm foul. So then I'm a for. Oma, yeah, log in on the team. Shall say. Uh, uh, ah, okay, okay. Nothing. All right. Hello. Yeah.
Good morning once again, colleagues and Honorable Regional Chief Pharmacists. Welcome to day 2 of the Pharmaceutical Services Annual Performance Review. Today is a bit packed, so we will go right into it. We will start with the opening prayer by Dr. Emmanuel Su once more.
All right, thank you. Shall we pray for this? Father, in the name of Jesus, we thank you. We thank you for the gift of life. We thank you for your preservation. Thank you for your protection. We thank you for bringing us together again for our performance review, the second day. We commit the meeting into your hands. We commit every deliberation into your hands. We ask that your spirit will help us, will grant us the wisdom, the knowledge, the understanding to bring out the best in us that would help push Pharmaceutical Services forward. We pray in Jesus' name. Amen.
Amen. Thank you very much for that powerful prayer, Dr. Usu. So I'll call on Director of Pharmaceutical Services. Okay, before that, we will want to do a small roll call. At this time, I will call the regions that are represented, and those that are present, please respond to that, unmute and respond to that. So we will start with Ahafo region.
We are here.
Ahafo is here.
Yes, Ahafo, we are here.
Kranti region. Kranti.
Hello?
Hello. Please hear from Ashanti.
Yeah, I'm here.
Oh, Chief Rista, you're here.
Thing that you just put there.
Okay.
Yes, I'm sent a message. Please check. Okay.
Simple representation.
All right.
Hello, Edna.
I hear you, Chief Rita.
Thank you. Bye.
Okay. Bono region.
Bono region, we are here. Bono is here.
We are here.
Yeah, Finn, is that you? Okay, no. Okay, Puno is here. Puno East.
I'm
here.
Okay.
send your friend in India.
Central region. Eastern region.
Yeah, I'm here.
All right. Western North.
Please, I'm here.
Western region.
Yeah, I'm here.
Okay. Upper East. Upper West.
Yeah, Upper West is here. Thank you.
Oti. Oti. Volta. Northern.
I am here. I'm on board.
Okay. Northeast.
I'm here.
Savannah.
Savannah, we are here.
I think that's about it. If I left you out, please prompt me.
Greater Accra.
Yeah, Greater Accra. Thank you, Pam Gifty. It usually happens to me that I leave the region I'm in out. All right, so thank you all for logging in and being on time. I will call on Director to give us the opening remarks.
All right. Thank you very much, Dr. Edna, and good morning to all of us. On behalf of the Director General of Ghana Health Service, Professor Kaba, Samuel Kaba Korea, and the Deputy Director General of the service, Dr. Caroline Unofemisa, and all directors at Ghana Health Service headquarters and regional directors of the service, I would want to welcome us to the second day of the annual performance review for 2025 and also the orientation for our newly appointed regional heads of pharmaceutical services. I must confess that yesterday I was so much impressed with the presentations that we had. They were so impressive, they were so informative, and they were so educative. We learned a lot. Ideally, this morning, the rapporteur should have summarized the event that transpired yesterday, but because of time constraints, we didn't do that. But what we'll be doing at the close of the meeting is that we are going to
Director's line has gone off. We can't hear him.
All right, so what I'm saying is that this morning, what we'll do after we have ended the session for the day is that we are going to organize an open forum. As part of our next steps, we'll organize an open forum and then discuss or brainstorm some of the key challenges that we saw or that cuts across the presentation, like in the area of human resource, in the area of medicines availability, in the area of dwindling funds, you get me? Challenges with managing medicines at the sub-district level. We are going to have an open forum and then identify the strategies to address those things so that we get committed to that. That becomes our goal for this year and for next year as well. So we all get committed to it. It will also serve as a guide going forward so that as pharmaceutical service, we can relate as one corporate body in Ghana Health Service with the same goals, with the same mission, and with the same vision. So we shouldn't think that immediately we are done with the presentation that has ended the day. No.
Then after that, we'll take about 30 minutes to discuss the key things that arose and how to address them collectively. On that note, I would want to hand the mic back to Dr. Enana to continue steering the affairs of this meeting. Thank you very much.
Thank you, Director. Just to reiterate what Director said, the open forum will be happening today. We are not organizing it any other day. Today, just after the presentations. Okay, so on that note, we will start with our first presentation by Western Region.
Okay, thank you very much, and good morning to everybody. Hello.
Good morning. Good morning, Chief.
Okay, so before I start my presentation, I will crave your indulgence so that all of us, we observe a minute silence for our departed sister, Farm Odame Kane Ifua, who passed and was buried this year. Let us observe 1 minute silence in her memory. She was one of our best, brilliant, pharmacists. So let's please observe that 1 minute silence, please.
Yeah. I think that's all. I'm going for the
Hello? Hello?
Hello.
Yeah, so thank you very much for helping me observe that minute of silence for our departed sister. So I'll go straight to Western Region. I'm presenting on behalf of Western Region. As part of my presentation, there are a few corrections that I'll be making along the line and some few inputs that I'll be making along the line whilst I'm presenting. And then after that, instead now I'll see if we could get access to what we submitted and then make those corrections so that you include them in the final document. So the population for Western Region for 2024 is actually 2,201,148. And then for 2025 is 2,247,278. So that is the population for Western Region. So that of 2024 will change. All this one, can you please go up a little bit more? Yes, here again, the number of sub-districts is both 90 for both 2024 and 2025. So it's typo, nothing else has changed here. Everything else is the same. So let's move on. Okay, so, please, calm down. Please, yes, let me speak to the app here. Yeah, so we have here also the, can you please calm down a little bit? Yeah, so the facilities, we have the OTCMS for retail pharmacies for 2024. It was given to me yesterday, updated, is 142 for retail pharmacies. And then 164 for 2025. 2024 is 142. And then for 2024, the chemical sellers OTCMS is 1,888 and 2,355 for 2025. Now, the total number of health facilities here, the figure here excludes the pharmacies and OTCMS. So when we include them, that of 2024 will become 2,711, and that of 2025 will become 3,200. That's the total number of facilities that we have. All right, so let's move on to governance and leadership. All right, so the region-specific challenges for 2025, like we heard yesterday, inadequate staff of all categories for facilities and the regional medical stores. And then also there's high number of non-mechanized staff, which is having a huge toll on many of the facilities that have engaged them. They are needed to be there to be employed so that the work can go on, and the numbers are huge. In fact, I have the total cost for 9 facilities that reported the amount to me. It amounts to 1,578,607. These are the amounts that the 9 facilities out of our 13 facilities are spending on casuals and that is huge, and that is having a huge impact on. They employ pharmacists and pharmacy technicians to ensure that the work is done. Also, we also noticed that there are a number of DTCs that are not functional in some of the hospitals. And in fact, across the region, antimicrobial stewardship committees were all absent in all the hospitals. There are also some facilities were having high rejection rates from NHIS claims. And then again, the sudden withdrawal of the LIMS software app during the last end of the year from October to December actually caused a lot of problems with data information. A lot of the facilities lost data on their NHIS claims. And then also some of the information that we are even asking them to report on, they lost them. So that was also a big challenge. And then Gilmer's utilization in the course of the year was also very low. We had 34% in 2024. So coming into 2025 was a challenge, so we had to do something about it. There was also poor inventory management at the lower levels. When we do supportive supervision and when we also do some engagements, as we move on, you will know that the management of the commodities at the lower levels was very poor. And that was leading to a lot of some of the challenges that they were not able to pay for their claim, their goods that they pick from RMS. So lower levels, poor management. It was being managed by, some nurses, some enrolled nurses, some community health nurses, and all of that, especially at the lower levels. Inability to undertake effective ward pharmacy practice. In fact, the numbers of pharmacists in the hospitals, some are having 1, some are 2. So it is very difficult for them to engage in active and effective ward pharmacy, which was one of the challenges we also identified. Again, some of the RUM indicators, especially usage of antibiotics, was very high, over 50%, while the national target was about 20%. Then RMS, in fact, Western region still remains the only regional medical stores, the region that is running our regional medical stores, the LMD, on our own resources. We don't use any third party. So we have our own fleet of cars, trucks that we are using. However, these trucks are very old and is having and the cost of maintaining these vehicles, and then fuel costs also affected the effectiveness of the last mile distribution. So the aged trucks was also another issue. And then across the region, most of the facilities are also not engaging in local manufacturing for a number of reasons. Some don't have the capacity, and also don't have the resources. Some also is staff, the numbers, they are not there to be able to do it for them. And then the debt servicing by facilities to RMS was also not that good, though we were making strides, but we needed to work on it to improve supply performance and the tracer medicines availability. And then also generally, the poor quality of pharmaceutical services across was also another challenge. Can we move on, please? So what were the region-specific priorities? There was the need to improve revenue generation, as I mentioned, that the debt servicing by facilities to the RMS was poor. So there was the need to strengthen, look at that. So the region have this committee in place put together by the then regional director, the regional accounts committee. This was put together, and that was specifically for debt collection, and also served as a supportive supervision tool for the region. And so we strengthened that. And what do we do? Every quarter, facilities are invited to the region with all their books, from the medical superintendent, the accountant, administrator, pharmacist, HR. They are all invited to the region and engaged. We engage them, and we collect monies from them to pay for their debt at the regional medical stores. And as we move on, you will see that this has really, really worked to improve the debt servicing performances by facilities at the regional level. Again, it was a need to improve quality of pharmaceutical service. We realized that the engagement of pharmacists was low. So we introduced the virtual means of engaging with pharmacists on bi-monthly basis, so that we will be able to disseminate information, the standards and practice guidelines, which were also to continue to disseminate through that means. And then also the reporting formats. We were also able to use that means to explain to members, pharmacy managers, how to actually use this formats, because some are still having the challenges with some of the data capture. Again, we also realized, like I mentioned, that DTCs and AMS's activities were not too good. So it also became a priority for the region to work on it, so that we're able to activate some of the non-functional DTCs, and also establish new ones especially the new polyclinics, which did not have them at all. And then also task the facilities to all of them, put together the AMS committees, and then we launch them and then put them in action. Also, we realized that as part of the challenges which the management of commodities at the lower level was poor, there was the need to, whether we like it or not, these people are managing these commodities that are going there on bi-monthly basis. The commodities are going, the medicines are going. They are the ones managing. Our people are not there. So what do? You need to at least give them some basic information on how to even order the other quantities. Some didn't even know what to order. And a whole lot, how to even calculate all of that. So there was the need to give them that basic inventory management capacity, so that they'll be able to manage, especially at the health center and the chiefs level. So where's the health centers where they don't have pharmacy technicians, where we have them, they are doing so well, but we don't have. So we needed to build capacity of these people. And then also Gilmer's utilization. Like I said at the beginning of the year, the Gilmer's utilization was poor. So what we did was that we set up a desk at the regional medical stores, which we call the help desk. And we had some of our trained pharmacists there and store supply managers who are well versed in Gilmer's. And then we set it up so that they would address the challenges of various facilities that are having challenges with Gilmer's. And it really, really also helped. We also had a Gilmer's coordinators for every district. There's somebody there who represents the region, and it was there to also support with the activities of Gilmer's in the district, and that also helped. There was also the need to improve RUM indicators across the region, and this we plan doing it using operational research, especially with the use of antibiotics, which we noticed that was very high. So we're going to use quality improvement tools where, fishbone methods and all of that are used to identify. There's the need to actually identify what are the root causes of all this. Though there are a few, but it was better to go into it do a research and really find out and come up with, lasting interventions that will help reduce the numbers and bring them to the fore. And then also the claims
Chief,
rejection rate.
sorry to interrupt. Chief, you have 10 minutes. Thank you.
I have 10 minutes to present. Okay, so let's move on. All right, so let's move on to the workforce amongst the others. So the farmer force, we don't have new postings. Let's move on. Let's move on. Can you please push it up? Yes, so here, again, can you please come down? So pharmaceutical workforce, again, the total number of pharmacists required was 94, and the number at post 29, the gap was 65. The pharmacy technicians was 276. It will change 276. Number at post 51, and so the difference was 225. Dispensing assistant. Here again, the dispensing assistant, apart from the hospitals and the health centers, it was 200 required, 3 at post, and 147 gap. But then yesterday we were talking about the fact that the CHIPS compounds are being managed by other health workers. So there's a need to actually make sure we make room for them. So I looked at the CHIPS facilities that we have. And then if we are to engage about 924 dispensing assistants or MCAs to be able to address that challenge. But if we exclude that number, our total number required will be 570, number at post 89, and then gaps will be 481. So I'll do those corrections as we move on. So let's move on. So the key clinical indicators, I think you can see them here. A significant figure here is the OPD attendance, some slight improvement from 2024 to 2025. Let's move on. Minor surgeries also, major surgeries also shot up from 14,000 to 21,000. Let's move on. Okay, so prescriptions, total number of prescriptions served per month. 2024 is 135,000 plus, 2025, 145,000. And then revenue in terms of insured clients is 36 million in 2024 and then 31 million. This 31 million is because some facilities lost 3 months data, October, November, December, which they were not able to provide because of the sudden withdrawal of the limbs. That is how come we have this drop. It was supposed to be higher than that of 2024. Let's move on, please. And the same for out of pocket. Yes, please, the interventions. Interventions for 2024 is 1,736, and then 2025 is 2,130. These are for 6 facilities. So patient safety indicators, let's move on. The clinical ward activities were supposed to be provided to me by the regional hospital. They were not able to give me because they claimed that the data, they lost it through the sudden withdrawal of the limbs. Let's move on to patient safety and quality improvement. So the prescribing, the medication errors, the total medication errors was 849, and majority of it, which is about 76%, that's 0.76 of the proportion, is actually prescribing errors. And then also the next one was dispensing errors, the others, all put together, 849. Outcomes of the medication errors, there was only one temporary harm everybody else recovered, and appropriate interventions made before dispensing that was done. Okay, so let's move on. The sources of ADRs reported were 108, and the medications are antihypertensives. That is the cardio. And then you also have the hydroxyurea, Effianquanta, oncology. Effianquanta is doing the sickle cell management, where they are using hydroxyurea in managing sickle cell. And that is why they are seeing a lot of reactions to the hydroxyurea. And then fluid and electrolyte 28, in total 108. Let's move on. Let's move on. Yeah, so the outcomes of these adverse reactions, no hospitalization. There was one life-threatening, but in total, everybody recovered. Now, when it comes to rational use of medicines, average number of medicines for 2025 was above the regional target of 3. It's 3.45, though it was 309. Percentage. In fact, all our indicators, apart from injections, which was within the range, almost all of the others were above the range. Apart from that, the consulting time was also within the normal range, and then dispensing time as well. Let's move on. All the others were off the target. Let's move on. Let's move on. Let's move on, please. Okay, so let's look at the supply chain pharmaceutical services at the regional medical stores. So for 2024, total purchases made was 47 million. And then for 2025, total purchases made was 61 million. Now, sales made for 2024 was 60 million. And then sales made for 2025 was 81 million. Now, total receipts here for 2024, it is the figure there is 55 million. It will change from this one. It's 55,888,585. And then for 2025 is 69,023,000. Now, payments to vendors, amount we paid to vendors for 2024 was 54 million. For 2025 was 44 million. And then total debtors for 2024 was 34 million. And then for 2025, 47 million. All right. So when you do the calculation for debt recovery rates, which I think yesterday somebody asked, I think Felix was asking how to calculate. So director gave the direction. So if you are to do what you received and then over the sales, for 2024, we are doing 92.97% recovery rate. But I think that there should be assumption. If you are to do your total received over your sales for the period or the month, then you assume that previously there's no debt. So if your debt brought forward is 0, then that formula will work. So if you consider the debt from 2023, which was 27 million, and you add it to what the sales, then you are doing a recovery rate of 59.3%. The same will apply for 2025. If we are to do sales, what we receive, that's 69 million over the sales of 81 million, you are doing 84.5% recovery rate. But there's a previous debt of 34,612,000, which you have to add to your sales for the year you are considering, because it's debt that you are also collecting. That one, when we put it together, we are doing a recovery rate of 57.5%. I think that formula should be, if your balance is 0, then it will be sales received over sales. Now let's move on. Summary: closing stock at the end of 2024 was 18 million. 2025 was 31 million. And the cash book balance was 3.4 million for 2024, and 2025 was 16 million. So we realized that the payments we made to our suppliers in 2025 was less, because as at the end of the year that we had not made our payments. So the money was sitting in the account, 16 million, which we immediately, the monies were paid, the processes delayed. And that for that reason, you see that the bank balance was quite huge, 16.6 million. Total creditors, 16 million and 3 for 2024, and then it shot up to 36 million for 2025. The net worth for our regional medical stores was 35 million in 2024 and 59 million in 2025. And our key tracer medicines availability shot up from 72% to 85%. Okay, so there's a debt schedules. You can see that the hospitals are owing about 46% in total of the debts that debtors outstanding of 47 million, followed by that of the CHIPS facilities, 28%. The two put together, the CHIPS facilities and the health centers put together, you can also see that they are also doing very, very huge, about almost 50% of the total cost of the debt that is owed. And this was, the picture is the same in other regions. Let's move on, please. Again, so the analysis of pharmaceutical class of products per the ATC classification, the blood and blood forming organs or agents, the one that is topping with 16 million, and then it's followed. Let's move on to the next. It's followed by the anti-infectives. So all the indicators are there. You can see that these are the key product that we are spending a lot of money on. Let's move on. Follow, and then in fact, the musculoskeletal is just about the 8. The third one is the nervous system products. Let's move on. Let's move on. Okay, so our working capital, as stated, is 35 million and 59 2025. That's about 65.8% increment. Let's move on, please. Okay, so our achievements. Yeah, we listed quite a lot because we thought that we are going to send this and then do some PowerPoint presentation slides. So I had a lot of information here. So among them is that we're able to roll out the SPGPS, that's the Standard for Practice and Guideline for Pharmaceutical Services. We rolled out here, we included all the pharmacists and the pharmacy technicians. We were able to train 42 pharmacists and 56 pharmacy technicians. And then also there was cholera outbreak and then mpox outbreak in the region. And I want to commend our pharmacists who are in the districts where these cases, were able to hold the fort together with RMS. In fact, I must commend one pharmacist in Wase Kropong, the recent mpox outbreak. He's doing so well. Robert Hayford, he's been doing so well over there to support the mpox outbreak activities. And the medical stores also, we were there to coordinate activities to ensure that the number of deaths were reduced. We also assisted FDA to review the warehouse certification of RMS. Okay, and then also we collaborated with FDA to do some training. Can we move on? Training in pharmacovigilance for selected categories of staff. Okay, so we also engage in capacity building on some of the districts, Tarkwa and Siaim, in inventory management, Tarkwa and Siaim, Wasa East, and the Huni Valley district and the Jomoro district. LMD activities were successful throughout the year. Regional medical stores was able to do all their 6 rounds of LMD. We do every 2 months, we visit all the facilities. We were able to do that. The setting up of Gilman's help desk at the regional medical stores was also done. And then this actually improved activity, the performance. In fact, we moved from 34% to 64% during the recent holistic assessment. And I think that was good, but then there's more room for improvement. Tracer medicines, I think I've mentioned it. And then debt servicing by facilities. In fact, debt servicing by facilities has improved significantly across. In fact, because of the RAC activities, we can see that we have over 50% of facilities all paying, doing 60%, above 60% debt servicing. And one of the things we've also done to improve this is that we also give awards to facilities that are servicing their debt well. At the regional annual performance review, they are awarded the best district that is performing in terms of debt servicing and also patronage of RMS. The same applies to the best district. And this has actually improved the performance. The district directors, the medical schools are all very much interested now. So we are doing so much well in the debt servicing, which is reflecting in our performance. All our key performance indicators are the RMS. You can see that they have all moved up. Let's move on. Let's move on. Let's move on. Okay, so let's look at conclusion. There are a number of activities that we did, but because of time constraints, I have to rush. Now, conclusion, the region will continue to work and collaborate with all the relevant stakeholders to pursue programs and activities that will ultimately improve the quality of pharmaceutical services being provided in the Western region. And recommendations, we strongly recommend that the introduction of the games must be expedited. And then engagement of new staff should also be aggressively be pursued. DTC and AMS activities outlined in the next steps must be prioritized. So let's quickly look at our next steps. The next steps, quarterly performance managers review must be conducted on a face-to-face basis. Bi-monthly engagement of the pharmacists must also be continued so that we'll be able to use the medium to undertake some education, training on key indicators, antimicrobial stewardship activities, and the review the pharmacy activity plan for the month, and to share best practices amongst colleagues. And then also a research team has been put together, and there's also a ward pharmacist team that have been put together as one of the innovations. We put together 2 teams from the regional hospital and 4 other hospitals around. What the team is going to do is that they will be visiting the hospitals to join the general ward rounds to be able to assist the pharmacists in the selected hospitals to do the ward rounds. In fact, this I have discussed with SMC, they have agreed, and the regional director has also agreed that the team, when they visit the hospital that they will visit will support their fuel and their per diem from coming. And this has been agreed upon. And this is one of the things we'll be doing in order to address the poor ward pharmacy practice because of the numbers. So we have this team, and we are going to start with 4 hospitals that we have selected: Efiam Kwanta Kwesimintim Hospital, Esikado, and Takoradi Hospital. They are going to start with that. Again, there's a support, antimicrobial support committee also supporting, and all the hospitals have been given timelines to form their committees, AMS committees. Some have done it. I was present in some of them, and it's ongoing. And then training of the capacity building should also continue. And then the district pharmacy concepts must be reviewed, and then they currently, so that pharmacists in the district will be given the opportunity and then supported actively by the district to be able to oversee some of the health centers and the CHIPS compounds activities, so that we'll be able to address some of the challenges that are currently happening in the system. And then there's a need to organize refresher training in DTC, and AMS activities must also be heightened and sensitization being done in the region. And then we also need to collaborate with our new regional director, and then we've been collaborating with the new regional director and the office of the director of pharmacy to continue to lobby for more staff for the region. It is very, very important. Let's move on, please. I think the highlights I'll pick from here is that we also want to, as part of the activities to improve their servicing, we want to organize supply chain conference by the end of June 2026, where awards will be given to facilities that are servicing their debt and also patronizing RMS. Not just our plaques, but this one, it's cash incentives will be given to them. And that also, we believe, will help boost the payment or debt servicing activities at the region. And then plans for local small manufacturing at the RMS should also be pursued, because we have started it and we think that it should be pursued. Again, there's installation of oxygen plant in the region. And in fact, I've been able to position the pharmacists such that we are actively involved in this plant. And it's medicine, and pharmacists, we should be given the opportunity to play our respective roles. If we are not careful, we will lose this opportunity and we'll come back and say, if we knew. So I want to say that as part of the next steps, strategic decision must be taken to ensure that whatever gains we have made in this area is actually sustained. Else, I will know what is happening. Other people would, infiltrate in there, and the roles that pharmacists are supposed to be played in this plant management to be given out. We also planned to buy one new 20-tonner truck. The process have started. We have pushed so hard, medical stores have worked so hard, and we've been able to start the process of buying a 120-tonner truck for the regional medical stores, a new one to augment the fleet that are aging. The Office of Chief Pharmacist will also have to engage at least one pharmacist to support the activities. It's not easy doing everything alone. So there's the need to engage at least one or two support staff for that office. We'll work very closely with our Director of Pharmacy and the Director of Pharmacy National Level Office, and then Regional Director and the SMC to have achieve much improved quality pharmaceutical services care that we need in the region. On that note, I will say thank you so much and I want to acknowledge and thank my pharmacists, my pharmacy technicians, who have all working so hard, bending their back. In fact, the numbers are so huge. Some will call you and say, Mr. Pinter, I just want to leave because I'm so much tired. I'm so much stressed, but they are all working so hard. I want to thank all of them. Thank the regional director and the SMC and also the Office of the Director of Pharmacy for the normal support they give us to achieve what we are seeing today. Thank you so much. Thank you. So I'm done, please. Thank you.
Thank you very much, Chief Appleton. It's very clear that Team Weston is doing a yeoman's job over there, and we commend you highly for what you have done and continue to do. Thank you very much. We'll be moving on to our next presenter, which is Bruno. But before we do that, I want to ask to acknowledge the presence of Dr. Mrs. Martha Jansaluthros. Auntie Martha, we see you and we appreciate your time with us. Thank you. And to remind the next presenter, please, you have 20 minutes for presentation. 20 minutes. We also want to acknowledge the presence of the chairman of GOSPA, Dr. Emmanuel Su Oriafe. Chairman, we thank you for being with us for these 2 days. Thank you.
Hello.
But no, please, we are coming.
All right.
No, please go ahead.
Okay, thank you very much. Good morning, Director. Good morning, colleague pharmacists. Chief Stephen Kwame Crime presenting on behalf of Bono region. So in 2024, our population stood at 1,309,454, and there was a slight increase in 2025. Next. Okay, the land size, administrative districts, and then the number of sub-districts still remain the same. Our regional hospital was upgraded to a teaching hospital. So currently we have the municipal hospital playing the role of a For private hospitals, we have 9. And then for the other public hospitals in 2024, there were 12. And then there was an increase to 17. Chiefs Compound 55 for 2024, 2025, 55. And then the model health centers for NOP 23. Next. Okay, it's worth mentioning that go back a little bit. Back. Okay, thank you. So in 2024, the number of retail pharmacies were 139, and then there was about 6 new pharmacies sprung up in 2025. And then the OTCMS were 1,122 in 2024, and that increased by a margin to 1,165 by a margin of 43 new OTCMS. So the total number of health facilities include the retail pharmacies and then the OTCMS. On governance and leadership, the following were the regional specific challenges: high level of facility indebtedness to RMS, and then high level of antibiotic usage, and then inadequate pharmaceutical care providers. Now, in documentation of pharmaceutical care interventions, despite evidence of clinical involvement by pharmacy personnel. Regional priorities as follow. 1, reorientation of prescribers and dispensers on rational use of medicine, and then to undertake scheduled technical support visits to facilities, and then give them the necessary training that is required. And then relines of the regional medical source warehouses, very, very important to us. So it's something we were set to accomplish. And then to complete the semi-automation of the regional medical stores production unit. That was one of our key priorities. And then to organize quarterly performance review meetings for head of pharmacies as well. Next. Now the pharmaceutical workforce. Hello. Okay. So for 2024, 2025, next, now a bit. Okay. Now at post, we have 4 specialist pharmacists, 28 pharmacists, and 35. In fact, this number should have been 5 for the specialist pharmacists, but unfortunately, we lost one of our colleagues in the person of Adams Yakubu in 2024. May his soul rest. So the total number of mechanized personnel, 96. Down. Unmechanized is 68. Next. Now let's move to the clinical services indicators. So total number of OPD visits 2 million in 2024, then 2,274,312 in 2025. 2025. And then the OPD visit per capita increased slightly from 1.63 to 1.68. Next, pharmaceutical care. The data is really not available. Let's move forward. Clinical ward activities. Next. Okay, so for clinical ward activities, 21.3% completed pharmaceutical care plans in 2024, and that saw a significant increase to 47.4%. And for drug therapy problems resolved, the percentage increased from 36.45 to 49.86. Discharge counseling, we saw an increase from 93 to 186. Next. Next, please. Okay, so under patient safety and quality improvement, we have on the whole 453 medication errors documented. 55% ascribed to prescribing errors, and then 20% for dispensing, and 18 for administration errors. Of all the 453, none of there was no harm for all the 453. Let's move to the next one. Then adverse drug reactions reporting. In 2024, there were 36 reports, only 36. It's doubled in 2025, and these are confirmed data from the Food and Drugs Authority, and these are the proportions accordingly. 43.1% for anti-infectives, which is clearly indicative of the high usage of antibiotics, and which was also evident in the 2024 RUM parameters. Hello. Okay, and then the next one was for the anti-parasitic products, 25%. The lowest of all was for the cardiovascular, which is 4.2%. Now the outcomes were as follows. 69 of such reactions saw no hospitalization, and then 3, in fact, with these 3 hospitalization cases, they were actually in the hospital, so it was more or less like a prolongation of hospitalization. Next. Okay, so these are the RUM indicators. Antibiotic use is still on a high, but actually saw a drop from 31.2 to 29.5. Next, please. Okay, stay right there. Okay, so for the percentage of prescriptions with injections, there was 4.2% in 2024. That rose slightly to 5.8. With some of the prescribers coming on board, the PAs and the rest. This is what the results was. Please, let's move ahead. Next. Next. Okay, let's move straight to pharmaceutical supply management and financing. Okay, thank you. So in 2024, framework contract purchases amounted to 3,913,532, and there was it was almost doubled in 2025 to 6,670,000. Non-framework was 9,922,686 in 2024, and that's dropped slightly to 8,738,446. But in total, the total purchases for 2025 saw significant increment from 13,836 to 50,409 and 32 Ghana cedis. And then the total debtors stood around 47,170,000 in 2025 as against 53,418 in 2024. And if you do the mathematics, you realize that there was an increase from 43.2 for the debt recovery rate to 62% in 2025. Okay, our net worth also increased from 47 million to 49 million, about 2 million plus a margin of 4.42%. And then tracer medicines availability also saw a slight increase from 81.3% to 83% in 2025. Okay, now the breakdown for the debtors, very, very important. For Bono, the chip compound and the health centers tend to lead the charts when it comes to the indebtedness. And you realize that for the health centers and the chips compound, they are almost at par, 33.17% for the health centers. That translates into 3,458,569. And then the chips is also around 3,418,000, also corresponding to 32.78%. This alone is almost around 70%. The hospitals is the second most highest, merging the chips and then the health centers. And then the least on the chart is the DHs. Next, please. Okay, for the analysis of pharmaceuticals by class and value, this is how Bono looks like. Yes, the blood and blood forming organs leads the chart both for 2024 years. The third chart is anti-infectives. And then the second on the chart is the cardiovascular products. Next, please. For the anti-neoplastic products, we did not make any of such purchases in 2024 and 2025. And in the previous years, it is the same. Okay, the working capital for Bono RMS, as I did indicate earlier, we have 49,817,000 for 2025, as against 47,614 in 2024, a margin of about 4.42. That is 2,202,512. Now to the achievements, conclusions, recommendations, and then the next steps. Bono region, we do monthly supplies or LMD, and so in 2024 and 2025, we completed 12 rounds of LMD, 12 solid rounds for LMD. And then we also ensured the licensing of the RMS warehouses in 2025, and then saw the completion of the semi-automation of the RMS production unit. Is one of the key priorities of the region, and we have secured a machine that is able to do the mixing, the bottling, the capping, and then the labeling. I think so, the new regions can pay a visit to the Bono region and see the production unit. Okay, we also initiated the license of the RMS production unit and then the registration of the products. And then there was a marginal improvement of RUM parameters, especially for the antibiotics use. that is from 31.2 to 29.5. And then also a significant increase in the working capital of RMS by 4.42%. And then we also added on with our product lines. So previously we were doing MMT, as per said, for pediatrics and then for the adults. Now we added on the episode and then saline drops as well. Okay. So in conclusion, despite the key challenges outlined previously, strategies were put in place, and then such strategies and activities implemented to address these challenges included the following: frequent technical support visits with on-the-job training at the hospitals and sub-district level, quarterly debt recovery exercise, and active involvement of pharmacists in the regional programs such as peer reviews and malaria OTSS training. Okay. In spite of these gains that were made, the year ahead demands more aggressive interventions from both the regional and national levels to deal with the other challenges. We recommend as follows. 1, a reintroduction and then enforcement of the district pharmacist concept. The previous presenter made mention of it, and we also retreat that point. Is worth noting. And then to engage BMC heads to come up with most effective and efficient way of debt recovery. And then recommend adherence to the bi-monthly on-the-job training in health commodities management at the district and sub-district levels. We also recommend the strict implementation of the decentralized recruitment for pharmaceutical staff. Next steps. 1, sensitization and advocacy for medication error and adverse drug reporting at the facility level. And then to continue technical support visits to improve rational use of medicine and train commodity management at the lower level to up their game in managing commodities, and then to come up with more responsive strategies for debt recovery to improve moderate debt recovery rate to 64% and possibly higher, and then to facilitate the functionality of the other non-functional DTC units, and then to complete the certification process for the production unit and registration of our products, and then to also train all pharmacy and dispensary heads on new reporting formats to get accurate and reliable reports. We think that this new reporting format need to be taken to the pharmacists and other heads at the lower levels to train them so that we can get better and reliable reports. And then to train all pharmaceutical care providers on the policy guidelines, pharmaceutical policy guidelines. On this note, say thank you very much for your attention. I'm done. Thank you.
Thank you also, Chief Crime, for another great job done. We are most appreciative of that. Thank you. Please, before we will open the floor for questions and answers, this time we will want to take 3 presentations and then we will do the questions and answers. We have noticed the presence of Dr. Abdullahi Abukari. That's the former regional director for Northern Region. I'm not too sure his current region now, but okay. Doc, you are most welcome and we acknowledge you.
Thank you very much. I'm enjoying your presentations.
Okay, thank you. Chief Memory, please. We will be projecting for you pretty soon.
All right, I'm on.
Chief Memory, you're up. Thank you.
Hello. Okay. Thank you, Madam Edna. Thank you, Director and colleagues, and all other senior members that have joined the team. Yes, Northern Region, present on behalf of Northern Region. Total population for Northern 2024 was 2,580,000 plus, and it has seen a marginal increase to 2.6 million in 2025. Please, can we move on? In terms of administrative districts, we have 16 districts, 84 sub-districts, one regional hospital, which actually need to take shape. Our Tamale Central Hospital is stepping in as our regional hospital since our regional hospital became a teaching hospital. We are still battling with that. We have 11 district or municipal hospitals from 10 in 2024. And we have private hospitals, 16 of them, also moving from 15 to 16 in 2025. We have faith-based hospitals, 6 of them. And in terms of NOP facility, we have 64. Let's move fast to retail pharmacies. The figures I gave, I just got some update on it, which I need to emphasize. When I asked for the data, they gave me community pharmacies and OTCs that were in good standing for 2026. So the numbers were low. So I queried, I have to ask again. The update is that we have 147 community pharmacy or retail pharmacies in Northern Region, and then 1,124 OTCs in Northern Region. That's the update. We have a total of 395 facilities across the region. Can we move forward? Governance and leadership. Human resource constraints. As already mentioned across board, inadequate number of pharmacists and pharmacy technicians across the region is a major problem. We have persistent rural and urban inequity in terms of staff distribution. And most of our health facilities, health centers, still operate without pharmacy technicians, and this affects quality of care in so many ways. Inventory management and so many other areas are affected in the absence of pharmacy technicians. Medicine availability and gaps and supply chain issues. Frequent stockouts of essential medicines at the facility level is a major issue that we are dealing with, and delays in supply from regional medical stores as a result of non-adherence of some facilities to the LMD schedule. We also have low utilization of GILMIX system by facilities in the Northern Region. We have high indebtedness of facilities to RMS, and again, that also leads to high indebtedness of Northern Regional medical stores to our suppliers, which every effort is being made to change the narrative. NHI reimbursement challenges and financial issues. We have delayed reimbursement affecting revolving drug funds. This as a result of delayed claim submissions by our facilities. So that's an area that they need to improve. Facilities need to improve the timeliness of submissions. Cash flow constraints leading to reduced procurement capacity of most facilities. We have low working capital of facilities across the region, with 3 of our hospitals currently posting negative net worth, which is a major threat to our survival. We have financial constraints due to a misapplication of drug revolving fund across the region, lack of enforcement of 3 mandatory signatories to the IGF drug account. This is an area that I think something has to be done. Sometimes being a signatory doesn't necessarily mean that if you don't sign a check, the check cannot go through. That is the fact that we need to take on. So moving forward, rational use of medicines and the gaps and the quality issues. Inappropriate prescribing practices, as we see in terms of high OPD antibiotics use, and then polypharmacy is a major issue that we have to deal with. And we have weak or non-existent antimicrobial stewardship structures in our hospitals. 2 of them were fortunate to be trained, but unfortunately the structures have not been able to survive. We need to revisit and find out what we can do. Inadequate drug and therapeutics committee functionality is also a major problem. Poor procurement, poor documentation of medication therapy interventions in some district hospitals. We also have weak pharmacovigilance reporting systems. Sometimes it's difficult getting our ADRs being reported on time. RMS infrastructure and logistics issues. We have limited digital systems for inventory and financial management and reporting. This is a major issue that our RMS will have to take on board. We still have situations whereby people are still doing more like manual, using Excel sheets and things. I think we have to move forward. Then we have poor transport systems affecting supervision and distribution systems, the LMD. As a region, we do not have our own transport systems. The support we get for USAID is still what we rely on. Regional priorities. Once again, we need to strengthen human resource. So we need to continue to advocate for recruitment and equitable posting of pharmacists and farm techs across the region. And there's a need for orientation and training for pharmacy workforce, especially the farm techs and pharmacists, and to implement task shifting strategies where it is necessary, still looking within the pharmacists, farm techs, and possibly MCAs. Medicine availability and supply chain optimization. RMS, we need to strengthen RMS, to facilitate supply coordination, to encourage facilities to adhere to LMD schedule. This is very, very important. We need to look at how to implement early warning systems for the stockouts that we experience. So we need to look at people, the facility need to be monitoring stock on hands, the amount of stock, and those kind of the minimum stock levels. And we need to look at these basic tools so that it can help us deal with that. We need to scale up utilization of GILMIS at the facility level, especially receipt and consumption, which is a major, major problem that we encounter. Antimicrobial stewardship is something that we need to look at carefully. We need to establish and strengthen antimicrobial teams, stewardship teams in all our hospitals. Implement aware, classification monitoring system in place. This is something that I hope I'll be able to start doing this year. We need to look at how possibly we can implement that and see where the issues are with regards to antibiotic use. Routine antibiotic use audits like the RAMS survey, which we need to continue. Strengthen NHIS medicine management. Improve claim submission quality and timeliness. We need to utilize claims vetted report to see where the issues are and resolve them. Track reimbursement cycles and advocate for prompt payments. At least 70% of our hospitals we expect should pay their reimbursed amount to RMS. And we need to keep tracking these things. Actually, the proposal which I have is that we need to continue our quarterly meetings with the MedSoup, the district directors, call on them to come and account for their stewardship. They need to pay the bills. Improve management of RDF, Revolving Drug Fund. We need to advocate for the enforcement of the 3 mandatory signatories of drug accounts to minimize, if not eliminate, the leakages. Improve debt recovery rate for 2026. So that is where we need to have a quarterly meeting for our MESUPs directors to come with the accountants, the pharmacists, and then we can judge all and get our monies paid. Can we move forward to pharmaceutical workforce? In 2025, we had no posting at all to the region. 2020, at least, can we move forward? But we were 16 pharmacists in the region. We lost 2 pharmacists. One left for the private sector, and the other moved to Upper East region to take up a post that was vacant. So that is the situation on the ground. So as we speak, we have a gap of 59 pharmacists that are needed in this region. For the specialist pharmacists, we had only 2, and we have a gap of 22. So in all, we have mechanized staff, we have 91 mechanized staff, and we have a gap of 292 staff that are needed to man the pharmaceutical services in the region. For non-mechanized staff, we have about 81 staff that the region struggles to pay monthly. That is not a mean job. And we have a total of 172 staff on board now, but we have a gap of 306 pharmaceutical workforce that are needed to hold the fort. Can we move forward to general clinical services? The total number of OPD visits per our records, this side we had a challenge. The explanation I get is that because of the sudden withdrawal of limbs, we lost data. So you can see almost all through, a few, with the exception of the revenue, the figures have all rather dropped. So they are not a true reflection of what happened in the course of the year, as we can see. So instead of total number of visits, 1,474,000, it's basically in 2024, it's just 1,424,000, which is not a true reflection of the event. OPD visit per capita, 11, it remains the same. OPD visits per insured clients, also hovering around, is even less than 2024. And total number of admissions, also less. So this is a trend. So an explanation is that we lost data because of the sudden withdrawal of limbs. Surgery, unfortunately, I need to provide that data. Yes. Major surgeries, I didn't have the figures early, but we have 6,407 for 2025. That's major surgery. Minor surgeries, 3,526,000 for minor surgeries. So we have a total of 3,511,000. That's death per admission rate, which is lower than what happened in 2024, which is an improvement. Right, pharmaceutical care, we move on. Total prescriptions, again, the figure is not too different from last year, which I believe is not a true reflection of events because of loss of data. But in terms of revenue, the region did better. 12.9 million as against 10.2 million in 2024. Again, in terms of non-insured clients, we have 4.9 million as against 3.9 million in 2024. So that is moving forward. In terms of total interventions, we had 2,229,000 as against 439 in 2024, which has seen some marked improvement. We hope to do better going forward. Can we move? Okay. Clinical ward activities. This is an area that is a very difficult one. We are trying as much as possible to adjust, to encourage pharmacists to do more. As somebody earlier stated, you have one pharmacist in the hospital, it is very difficult for them to come up. But we hope there's a hope on the way, which we want to exploit. I will be talking about that in due course. So generally, our performance there is not that too good, but we can see emergency medicines at least 63.6% availability is not bad. Prescriptions, we had 676 prescription errors, which was the highest, followed by dispensing errors, which is 14.9%. And then it goes, so we had a total of 920 medication errors that were reported. And there was no harm reported. In terms of the adverse reactions that were reported, blood and blood-forming organs had 14.3%, and anti-infective, once again, as shown across the presentation, 35.7% was the highest, followed by cardiovascular, 28.6%. We have the total of 16 adverse reactions. I need to make some correction here. I think the outcome of adverse reactions, the figure posted was in error, so it's supposed to be 14 in total. We had 2 inpatient admissions, but later they recovered. There was no problem. 1 life-threatening, but also recovered by Allah's grace, so there wasn't any death. Rational use of medicines, polypharmacy is the bane. It is a big issue. We had 3.22 as again 3.12, so we've been struggling to achieve the target. In terms of antibiotic use, as usual, those we saw slight improvement, but it's still 46.57. Injection use, it has always been good, but we are seeing a sudden trend that is upward trend, which is not good. We need to tame it. Generally, with regards to consulting time, there's a slight improvement. Dispensing time also almost the same. In terms of percentage of prescribed medicine that were dispensed, unfortunately, it reflects where we are, 55.19%. It doesn't look too good. And adequately labeled, we have 76.9%. Can we make progress to pharmaceutical supply management? Hello? Yes, this area we've seen, though in 2024, I understand there were some issues there. So the figure is not a true reflection of what happened in 2024 because we couldn't get some of the data. But in 2025, we saw 1.3 million purchases with regards to framework contract. And non-framework contract also saw an upward. So generally, we saw 25 million worth of glass purchases as against 19 million in 2024. We also saw annual sales increased. But unfortunately, the data suggests our receipts dropped. Compared 19 million as against 21 million, which we did in 2024. So meaning we have a work to do in 2026. So generally, that is a picture. In terms of our debt recovery, 2024 was 40.58 as against 31.9%, which means there's a lot. And that goes back to the point that we need to meet our creditors, our debtors quarterly so that we can ask them to do the needful. In terms of indebtedness, we are in the range of 21 million. And our net worth has appreciated slightly. We have also seen some improvement in terms of our tracer medicine availability, though we are at the bottom, but we hope to come up strongly in the near future. 52%. We hope to come up strongly. The breakdown, I can see almost all regions are doing a better breakdown in terms of indebtedness. The health centers, the chips, but unfortunately, in our situation, there's a gap there, which means that we have to fill that gap. We need to be able to have very specific figures for the health centers and the debt, instead of accumulating everything under the DHs. But looking at it as it stands, the hospitals are holding 50% of the debt, and the non-Ghana health service facility 4.4%, very marginal. Can we make progress? the ACT classifications. Generally, ACT classifications, the blood and blood forming organs in 2024, I mean, had a top number one position with 1,780,000 plus, but it has taken the second position in 2025 in terms of ranking. Then we have anti-infective systems, systemic use, taking the second position with 865,000 in 2024, and now taking the first position in 2025 with 6 million or 6.5 million. Now we have the nerve system agents taking the third position both in 2024 and 2025. Unfortunately, I must say, with regards to our disposal or expired medicine, I'm here to attach the list. I asked for it to modify it as presented, and I'm here to get it. Working capital. Well, after this one, I have a question there. I don't know the working capital is the same as the net worth. We'll have to put that question when the time comes. Achievements and conclusions, recommendations. Service delivery improvements. We have seen improved availability of selected tracer medicines across the region. At least the RMS have shown that. We have 44% in 2024. Now we are talking about 52%, meaning we are making progress going forward. With regard to framework contract medicines, I have not shown that on the board, but later when I checked on it, we had less than 50%, but now we have, in 2025, we scored 70+% in terms of having framework contract medicines available. Improve clinical pharmacy services in regional and some district hospitals. This is something that we need to continue to pursue and improve as time goes on. And capacity building, training conducted for pharmacists and pharmacy technicians happened, especially the rollout of the standard practice guideline happened last year. We have a rational use of medicines training also done. Logistics and supply chain management also training was also done to help our facilities to improve their service delivery. Now, system strengthening, we have improved data reporting rates from some hospitals. At least we are seeing some improvement. There's also increased documentation of medication therapy interventions during our ward pharmacy activities. This is an area that we think we can do better in 2026 going forward. The good news is that we have about 9 pharmacy house officers posted to the region. So at the regional hospital, we will engage them. We've already started engaging them. We are giving them orientation, and we'll be engaging them to do more. And we are asking that the next batch, more should come to the region so that they will help us to deal with the ward pharmacy practice issues. Public health coordination, there's active participation in disease control programs like malaria, TB, and HIV programs across the region. Improved integration of pharmaceutical services into clinical care is something that is always ongoing. In conclusion, pharmaceutical services in the northern region continue to play a critical role in healthcare delivery by ensuring access to safe, effective, and affordable medicines. However, systemic challenges, particularly human resource shortages, supply chain inefficiencies, and financing constraints continue to limit our optimal performance. Despite these, notable gains have been made in capacity building, service expansion, and system strengthening, providing a strong foundation for further improvement going forward. That is our hope. We hope we can do better going forward. Recommendations, policy and governance. We need to continue to advocate for Ministry of Health to fast-track recruitment and posting of pharmacists and pharmacy technicians to the region. This is very, very important. And to strengthen enforcement of medicine management policies, advocate for RMS to acquire a telesoftware, a software that can help us integrate our inventory management with our financial management so that we can get a clearer picture of what we are doing. That is very, very important, and we are working on that. Financing, advocate for timely NHI reimbursement to our facilities, and we need to increase budgetary allocations for medicines especially this direct to hospitals, they need to allocate at least 70% of reimbursed amount to RMS so that RMS can stand on the feet, paid suppliers, and then we can ensure availability of all medicine. Almost all our peers are above 60, 70, 80, 90% of tracer medicine availability. We cannot be satisfied with 50%. Service delivery, we need to scale up clinical pharmacy service across all hospitals and institutionalize antimicrobial stewardship programs. This is something that, again, I hope we will rely on the pharmacist, houseman officers, so that we can drive this world pharmacy activities. Now, RMS, we need to improve forecasting and procurement planning. Very, very important. We need to strengthen our capacity in terms of distribution as well. But the human resource gap is also there. As we speak, our RMS has only one pharmacist, only one pharmacy technician. But we are making every effort. Even before we heard of this, can be paid on casual basis. We are still on it. We hope this clearance will help us out of this situation. Digital health. We need to accelerate adoption of electronics. We had LIMS, which was doing well. Now we have GIMS. As we speak, it is a matter of concern. We don't know how GIMS is moving forward. I understand January to March, our hospitals are unable to submit their claims. This is a matter of concern. Some of the big men, I understand our former director is on board. I hope he got this message for us. Monitoring and evaluation. We need to strengthen supportive supervision and also use data for decision making. This is something that we hope to do. That is the backbone we are going to write on. Next steps. We'll conduct regional support supervision in all districts, as always we do on a yearly basis, and roll out AMS checklists and antibiotic audits. Here, I hope we'll be able to apply the WHO principle to see where the actual problems are, what kind of antibiotics have been prescribed, and the mode in which it's been done. And also address critical stockouts of essential medicines. Again, we need to monitor our monthly consumption, our stock, amount of stock, and the stock on hand, so that we will understand when there's high risk of shortages, we'll be able to move in quickly and stop it. This will share the knowledge with our staff, the workforce, so that they can move forward. Now, we need to deploy digital stock management tools at the RMS. Again, a software that will integrate our inventory and financial management at the RMS. Very, very important. Strengthen DTC functionality in all our hospitals. This is something that we are looking at. And improve NHIS claims processing systems. Again, our claims, our hospitals need to submit their claims. Other than that, it just, I don't know how RMS will be able to survive without them paying back. Because last year, we gave out so much and the money was not coming. We need to change the narrative. Lastly, we will endeavor to achieve equitable distribution of pharmacists and farm techs across all districts, and fully integrate pharmaceutical services into universal health coverage as our theme suggests, and establish a robust regional pharmaceutical data dashboard. This is something that I hope a few of the indicators that are critical will be shared on quarterly basis, so that the entire region will know our direction. Thank you so much, Director. I'm grateful for the opportunity.
Thank you.
I'm done.
Thank you very much, Chief, for another wonderful presentation.
Thank you.
And thank you for the good job you are doing despite all the challenges. Okay.
Thank you.
Okay, we'll be opening the floor for our questions and contributions. But before that, we want to acknowledge a few people. Dr. Yafin, we can see you. That's the RMS manager for Bono region. We appreciate your presence here. We also see from Munira Tuseidu, Central Hospital, Tamale West Hospital. We appreciate your presence here. We appreciate all of you, actually. It's now hard for me to pick the facility heads that are here, but we are most grateful that we have your presence with us for this year's performance review. On that note, please, I want to open the floor for our questions and contributions. Dr. Daniela Powell, RMS Manager for Northern Region. I see you. Thank you for being here. Please, the floor is opened. We had presentations from Western Region, Bono, and then Northern Region. So please, let's ask them our questions or give them our recommendations.
Hello.
Hello, please go ahead. Please introduce yourself first.
Yeah, friend. My question goes to Northern Region. I saw average dispensing time as close to 2 hours. I'm wondering why it takes that long time for them, the patient to get their medicines. It's close to 2 hours, so I'm not getting the indicator right. Is it not the time it takes for patients to get their medicines when they get to the pharmacy? I need a clarification though, but I was surprised as to the 117 minutes quoted there. That is close to 2 hours. Is it that the staff strength is not enough or what? I don't know.
About seconds.
All right, well noted. Thank you for that question, Dr. Yafin. Any more, please? Any question for Western Region?
Hello.
Yes, please go ahead.
Good morning, Director. Please, mine is a recommendation that I want to make out of the two presentations.
Yourself first.
Thank you. My name is Robert Clifford, a pharmacist at Wasekopo Hospital in the Western Region. Thank you. Please, can I go on?
Yes, please.
Okay. Please, my recommendation one is the concern about pharmacists or pharmacy technicians in the district. If you see the presentation made by the Western Regional Chief Pharmacist, you can see that there's a lot that is in concern about the district as to promoting health. Now we have rising cases of NCD and AIDS management. When you go to the district, you see that the drugs are being managed by what we call nurses and then midwives, sometimes even lay nurses. So I am pleading that it will be possible pharmacists or technicians are employed to get to those areas and then monitor the medications. Sometimes we have to get some of the technical things that we can do extraordinary from all other cadres. Those are some of the things that pharmacists we need to do so that we can add it to our condition of service. Technical things like what we call pharmacovigilance reports and then the data to show that this care that we are doing over there, just to help us in our what we call our condition of service. My second recommendation again is going forward. I wish that we have stakeholders like the Pharmacy Council and the media also to be part of some of these our programs that we are having today. Maybe if it's an in-person meeting and then we invite all these stakeholders to come and observe what we are doing, we look at their impact, and then we highlight it on television and radio stations for them to see. I think it will help us to market the image of our pharmacy. Thank you very much. Larry.
Thank you, Mr. Hayford. We heard you loud and clear. Thank you. I'll call on Dr. Obiafe.
Okay, yeah. So thank you very much. Yeah, I wanted to commend my regional boss, Farm Stephen Kwame Croin. I just want to use this platform to just commend him for how he carries, all of us along, though some of us work with, CHAC facilities, and I think we've had a very cordial relationship in the region, and I just wanted to commend him for all that he's doing. Yes, I realized from the presentation so far, particularly Northern region, has gotten to do with the challenges on the management of the revolving drug account, etc. And I believe maybe the open forum section will maybe give us an avenue to maybe narrow down on some recommendations that will go a long way to help improve our drug availability and then reduce the indebtedness of some of the facilities to the regional medical store and help improve the drug supply situation in the various regions in total. Thank you.
Thank you, Chairman, for those comments. Please, is there any more? Then I will leave it for the Office of the Director to make a comment.
Thank you for the nice presentation, Chief Appington, Chief Memory, and then Chief. I think you guys are on point. And we thank you so very much for that detailed presentation. In fact, I'm so much impressed with what I've heard this very morning. And going forward, like Dr. Rafi said, during the open forum, we'll just make time to discuss a few issues that we've identified which are cross-cutting that we need to address to enhance the delivery of pharmaceutical services in Ghana Health. Thank you very much.
Thank you, Director. Okay, a few observations I'm also making, and it cuts across. It looks like most of us will have to redo the reports, if I may say that. Few data was missing in most of the reports. And as you are making the presentation, a lot of corrections are being made. So please, I will entreat, or we will entreat all of you to input all the missing data, make all the corrections, and resubmit the reports to us once again. Thank you. Okay, on that note, we will give a 5 minutes break to stretch, and then we will come back and take the next batch of presentations. So 5 minutes.
Hello.
Yeah.
Hello.
Yes.
Please,
Chief.
can I respond to the question?
Oh, okay. I'm sorry.
Okay. With regards to the dispensing time, yeah, yesterday I had wanted to make some inputs into that. Dispensing time is recorded in seconds. It is not in minutes. So consulting time is done in minutes. Dispensing time is done in seconds. So the 117 is talking about seconds, and that is less than 2 minutes. So that is the correction. Now I wanted to actually say that in the format, in the template, it's good we indicate the time, whether it's in minutes or seconds. So that should be attached so that we can avoid this kind of understanding or misunderstanding. I hope I'm clear. So we are not talking about hours. It's in seconds.
Okay.
And that is the WHO standard.
You are
So we
clear
are talking
on
about
that?
1.2 minutes, less than 2 minutes to dispense. Okay.
Okay, Chief Memory, you are clear on that. We've taken note. We'll make that input in the reporting format. But
Sure, thank you.
I think we all need more education and clarity on that. So thank you. Mr. Quaker, please, do you have something to say?
Oh, not now, please.
Okay.
Yeah.
There's a personal message.
Yes, please. Okay, before we go, please, there's a message in the chat and I want to read. If dispensing is less than 2 minutes, do you carry out counseling as part of dispensing? 2 minutes is quite a worry to me, noting you have to educate the patient. Thanks. Please, can anybody respond to that? 2 minutes to dispense. From the time the patient comes to the pharmacy to the time they go, 2 minutes. I also have some concerns there.
Yes, I think we have different types of dispensing. It depends on what you want to do. If you are bringing counseling a patient is a different matter. But if you are just dispensing, the WHO standard is 90 seconds, 1.5 minutes. That is the standard that regards to the survey we are supposed to adhere to. So it means here we are even doing more. We are doing more than the 90 seconds. Yes, it is true. Sometimes the clients will need. So in situations where you need more time, yeah, you have to give more time. But this, we understand, is an average. It doesn't mean everybody is getting this or less or more. Some will get more, some will get less time. I think that's the realistic.
All right. Well noted. Yeah, there are two forms of dispensing. I think we will need clarity on it. What you are describing to me is emergency dispensing. And if that is within 2 minutes, that is okay. But for standard dispensing, it cannot be 2 minutes. In my view, it cannot be 2 minutes. From the time the patient comes for you to even do your assessment, pick, label and everything, and then do your usual counseling, it cannot be 2 minutes. If everybody is coming and we are dispensing in 2 minutes, then it means we are too efficient at the dispensary. I'm not talking about...
Can I add this thing?
Yes, please.
Madam Edna.
Yes.
Can I add this information? You see, the survey talks about certain criteria. It measures this dispensing time. Immediately you start talking to the client when you are actually doing the dispensing in terms of giving the medicine to the client. The process involved is not part. You packaging and labeling and all those, they are not part. When you call on Musa and the Musa stands up, he comes to you and you start educating him on the medication, how to use in terms of dose, frequency, duration, and maybe some side effects and purpose. That is what we measure.
All right, Chief. Thank you for that clarification or education. And I think this education must go to all of us so that we don't assume that it is the time the person comes to the pharmacy and then the time he leaves. I mean, that time period he spends at the pharmacy is the dispensing time. It's the time we call on the person to give the medication after all the processes. So thank you. But I think this is something we will take notes to educate all of us.
Good.
On that note, please, now our time is 3 minutes. We have 3 minutes to stretch and then come back for the next presentation. And the next batch will be taken by Greater Accra, Ashanti, Greater Accra and Ashanti region.
Ah, yeah. Oh, ah. Woe to me so. Woe to me so. Oh, sabe rima. Ah, yeah. Oh, ah. Woe to me so. Woe to me so. Oh, sabe rima. Aye. Oh, ah. Daddy would to me so. Woe to me so. Na ye beka. Would you man in every say, would you mind? Yeah, see, oh, oh, sa, bury my, oh, would to me so, would to me so, now, yeah, Becca. Osaberry, my woe to me so, woe to me so. Osaberry. Woo to me so, woo to me so. Sabe bima aye, oh woo to me so, woo to me so. Osa berima aye hoa woo to me so.
Hello. Welcome back, everyone. We will proceed with the next batch of presentations, beginning with Greater Accra. Greater Accra region.
Hello, good afternoon.
Good afternoon. Please proceed.
Okay, thank you very much. Good afternoon, Director and your team, for the wonderful work. If I'm permitted, I use this opportunity to acknowledge all my pharmacy managers who have joined. And then my incoming boss, Chief Felix, I salute, sir. My name is Gifty Yangmo, the caretaker chief of Greater Accra region, and I'm presenting on behalf of Greater Accra. Please move. Yes. So by way of introduction and background, here in Greater Accra, establishing pharmaceutical standards, stating challenges and providing solutions, ensuring increased workforce, providing equitable essential medicines that are cost-effective, among others, are key accelerated actions for achieving universal health coverage. Now, let me give you an overview of Accra. That is with our densely, population. If you look at our population, it increased in 2025. That is over 6 million as compared to the 2024. Here in Accra, we are densely populated, spanning from urban, peri-urban, and then rural communities here in Greater Accra. With this increased population, please, can you? Yes. With this increased population, if you look at, we have 29 districts which have not changed as compared to 2024. We have sub-district 119, same, one regional hospital, that is the Ridge Hospital, 16 district hospital, 174 other public hospitals. Please, let's go down. We have 37 CHAG. We have 53 Model Health Center. Please go down. For retail and OTCM sellers, we didn't get the data at the time of this presentation. We will really do that and update our report. So in total, excluding those two, we have 1,570 health facilities here in Greater Accra. Please, let's go. Governance and leadership. So when you come to the challenges here in Greater Accra, we have inadequate number of pharmacists and then technicians. As run through all the presentations so far, it's been that is the biggest challenge here as well here in Greater Accra. We have inadequate working space at the facility level. That is a place for counseling patients. For patient privacy is a challenge in our region. Some RUM targets not being met, example, the antibiotic use in our region, stock out of essential medicine, especially the framework contracting. Here in Greater Accra, we as a region, we don't tender for the framework contracting. We fall solely on the call-offs from the MOH. And then poor GILMIS utilization by the region, especially the health centers and the smaller facilities, although with the implementation of those GILMIS, like they are actually not using that. And then delay in health insurance reimbursement. Also, periodic shortage of some program and essential medicine also affects delivery of service. And then regular walk-ins by facilities at the RMH, which disrupts the LMD process. I don't know whether because we are close to the Mokola, so people prefer to do the walk-in and then do their own rounds whenever they come to medical stores. Also, inadequate storage space in the regional medical stores. It's one of our most challenging here in the region, but we are finding ways around it by optimizing the little space that we have. When you look at the presentation yesterday, the director made, you could see that we are rocking shoulders with the big sisters and the big brothers, that is Ashanti and then Eastern region, despite our limited space challenge that we have. We are just practicing just in time because we have an advantage here in Greater Accra. Most of the suppliers are here with us, so we are able to call them, and then as soon as the commodity comes, it moves. And then uncompleted RMS at the Pantine. It is also our biggest challenge. It has been there for over 15 years. So regional priorities, please go up. Is to recruit and retain more pharmacists and pharmacy technicians, which is a wish of, I think, all the regions. That is our wish, and then that is our priority. And then to provide continuous training and capacity building for existing staff. Gradually also mechanized and then digitalized pharmacy processes, that is dispensing, stock management, and documentation. And then expand and redesign hospital pharmacies to include standard counseling rooms, and then ensure facilities met minimum requirement for patient confidentiality and effective service delivery, and strengthen antimicrobial stewardship in the health centers. And then enhance pharmacy-led interventions to reduce irrational antibiotic use, and then involve pharmacists as signatories to the drug revolving fund. This year, last year we realized that most pharmacists were not signatories. So director, we spoke to director, and a directive went to all MESU, enforcing this directive to make all pharmacists mandatory signatories to the drug accounts, and then strengthen pharmacist participation in drug procurement, accountability, and then fund management. Let's talk about the pharmaceutical workforce. Achieving universal health coverage requires well-trained pharmaceutical service providers. Here in Greater Accra, the total workforce, as we see, is about 547. For the breakdown for posting of pharmacy staff, the whole of 2025, we had only 2 pharmacists and 1 technician. And if you look at the breakdown of the mechanized one, we have 21 specialists and senior specialists, 125 of pharmacists, and the number required was 181, so a gap of 56. Pharmacy technicians, 79 as to 321, a gap of 242. Dispensing assistants, 80, a gap of 52. So, we have a mechanized staff, 305. Go down, please. And then for non-mechanized, please go up, sorry. Scroll down, yes. And for non-mechanized, we have 242, making a total of 5. Down, please. Making a total of 547. And as I said here in Greater Accra, 547, taking care of a population of 6,130,000, over 6 million, meaning that one pharmaceutical care staff is taking care of about 11,000, over 11,000, which is 5 times more than the accepted, that is one pharmacist to 2,000 population by WHO. So even with the addition of the non-mechanized staff of 242, the data and then other analysis do not even give any better narrative. And there must be a full optimization of every opportunity for our voices to be heard in recruiting pharmaceutical workforce. When we look at the clinical indicators, the number of OPD visits is slightly increased to 60, that is 6,819,336, as compared to slightly increased as compared to 2024. And when you look at the OPD visits per insured client, also increased from 31,000 to about over 33,000. Sorry, from 315,000 to over 330,000. And then when we look at the hospital admission rates, it also increased from 50 to 51.3. With the major surgery from 23, we reduced to 22, which is a good sign. Hello, the screen is off. Yes. And then total number of patient deaths also reduced, which is good for the region. Pharmaceutical care, please go down, sorry. If you look at the number of prescription per month, 2,000 as at 2024 to 2,667. There is an increase, but I think I will talk to my managers because it looks like our report, we are under reporting on this, but I will encourage them going forward to report more. If you look at the average per a day, prescription per day, 71, 2024, for 2025, 89. And then insured clients also went up, that is 9,000 from 9,479 to 11,761. The insured clients revenue also increased. If you look at 2024, it was somewhere around 248,430 as compared to 2025, 513,834. And then out of pockets payment, that is in numbers, that is 15,000 increased to over 20,000. And then for the revenue, out of pocket also, if you look at it, it increased from over 1 million to over 2 million. Please, let's go. So here in Greater Accra, with this, it actually helps us, although there are delay in health insurance reimbursement because of the out of pocket, normally is around 70% in our revenue, they are able to pay medical stores, and we are also able to pay our suppliers also in time. When we talk about interventions, we have 254. Forgive me with my numbers. Please go down. Yes. So for the clinical activities, for the drug therapeutic problem resolved, 2024, 100%. And then when you come to 2025, see. So when it comes to the medication errors, well, okay. Okay. So the medication errors prescribing is 177, and that constitutes about 69%. Am I the only one? Okay. And
no,
when
it's not you only.
Dispensing also constitutes about 3.9%. Administration, that is 2.9%, and then others 23.6%. So a total of 254 errors, and then making about 100%, and all of them were resolved because of the timely interventions of pharmacists. So there was no harm caused. Down, please. Down. I said that there are some gaps that we need to fill later after this presentation. Yes, so outcome of adverse drug reactions. So no hospitalization, 9, they all recovered. And then when it comes to the rational use of medicine survey indicating, if you look at average number of drug per prescription, that is 2024 is 2.69, but we came down, that is 2.45. The decrease was not that much, but I think we are doing well. When it comes to percentage of medicine prescribed by generic name, we did not reduce, rather we were going up. So I encourage my managers to do so since they are online. And the percentage of prescription with written antibiotics, we are also not doing well at all, from 87% to 90.9%. And the percentage of prescription with injection is also going up. That is 90% as compared to the 87.7% last year. Go down, please. And the percentage of drug adequately labeled, 100%. Down. So when it comes to the pharmaceutical drug management and financing, that's summary of our operation in Greater Accra. For framework, for 2024, we did over 9 million. But when it comes to 2025, we did over 11 million. And then from non-framework, over 47 million as to 2024, and then over 76 million for 2025. So our annual sales for 2024 was 56,884,770. And for 2025, we did 87,887,223. The sales, annual sales, also increased. If you look at 2024, 71,483,863, as compared to 101,308,231. Our total receipt for 2024 was 69,278,101, as compared to 2025, which increased to 82,077,892. So payments to vendors as compared to 2024. 2024, we did about 66,977,990. And then for 2025, we did 85,040,330. So debt recovery rate, we could not do that at the time of this presentation, which we will do and then duly update our reports. Please go down. So our closing stock value for 2024 was 16,182,510. And that of 2025 was 24,258,624. Our cash book balance for 2024, at the end of 2024, was 13,520,934, as compared to 2025, which has reduced, that is 10,343,904. So total creditors as at the end of 2024 was 6,956,439, as compared to 9,803,327 for 2025. And net worth for 2027 at the end of the year was 70,801,549, which has actually increased to 91,076,541. It means that we are doing well and rocking shoulders with the big men and women on this platform. So are they scheduled by facilities? If you look at it, you can see that hospital and polyclinics are keeping a lot of our money. If they constitute about 81%. And then the district 1.1%, the health centers 15%, the CHIP compounds little above 1%. So in total, facilities owe us about 65,097,000. What is this happening? Why is it happening to me? 65,097,926. Please go down. Please down. As I said, there are some gaps that we will duly. So working capital. When you look at our working capital at the end of 2025, if you look at it for 2024, we had 69,314,593, as compared to 2025, that is 89,802,006. It means that as a region, we are doing very well with this limited space that we have. Achievements and conclusions. So achievements. So to enhance facility oversight, we'll have to conduct a supportive, we conducted a supportive supervision to multiple facilities like Ablekuma North, Amanfro, Mamprobi, Atebiokoshi. And then community engagement through some of the celebrations, like the World Hypertension Day, and then the antimicrobial. Hello.
We can hear you. Please go on.
Yes. Okay. And
yes,
then also we improve medicine management. That is, we monitor the availability of essential medicine in hospitals and polyclinics, and also strengthen the drug and therapeutics committee through regular monthly reporting and then follow-ups. Also, there was capacity building. We delivered refresher training on rational use of medicine, which we are also going to even do recently. And then antimicrobial stewardship by initiating and promoting antimicrobial stewardship activities and promoting rational use of antibiotics, reducing risks of resistance in some of our facilities. Please go down. So, in conclusion, the pharmacy unit has achieved a lot, even in the face of numerous challenges, and it is the hope of the unit to continue to collaborate with stakeholders to overcome our challenges and improve pharmaceutical service to the people of Greater Accra. It is a hope that we do much more to achieve this. And then in recommendations, the chief pharmacist will provide a supportive and monitor the DTC activities and the RUM, and then also collaborate with the RMS manager to work to improve on the availability of medicines, essential medicines, especially the framework. And also the chief pharmacist, also with the help of the regional health director, also advocate for recruitment of more pharmacists, staff, and technicians to help improve the pharmaceutical service delivery in the lower facilities. So ultimately, the next step will require collaborative, innovative, and commitment to advancing pharmaceutical services for all communities in Greater Accra. Thank you very much. Hello.
Hello, Chief Gifty.
Yes.
Well, we
Yes,
can hear
the
you.
next step, I have summarized it by saying that we will collaborate and innovate and committed to advancing pharmaceutical services for all communities in Greater Accra. Thank you very much.
Thank you. Thank you for a wonderful presentation. And we are sorry for the technical hitches. It was from our end, so it's not you. We are very sorry. But we notice also that you have a lot of missing data. I know you do the right thing and send it back to us. So thank you very much. We will move on to the next presentation by Ashanti region, to be followed by Western North. So Ashanti region, just a minute. Your presentation will be on the screen. Thank you.
Hello, Edna. Hello, Edna.
Yeah, Chief Rita.
Yes, I submitted a new jot form.
Yes,
and I would want to work with that.
Yeah, we are projecting that one.
Okay, then. Thank you. Okay, so Rita Usudonko, Chief Pharmacist for Ashanti region, and I'm presenting on behalf of my region. Our total population for 2024 was 5,649,000, as against the population in 2025, which is 5,751,000. So our total landmarks in square kilometer is same. On this slide, what has changed? Please move up a bit. What has changed is the number of hospitals and the number of metropolitan and district hospitals, which is moving from 20. Which is moving from 28 to 32 as a result of the addition of new hospitals in the region. Please move on. And then on the OTCMSs, last year we didn't take the data, but this year retail pharmacies in the region is 1,067. And then OTCMS sellers is 4,700. So the total number of health facilities is 6,632. So we move on to section 2, which is governance and leadership. Regional specific challenges. The first one is the shortfall in pharmaceutical human resource, which I think has run through all the presentations from the regions. What I would want to mention is that out of a total of 41 PharmDs that were recruited and posted to the region. 26 of them are left at post as I speak. The difference have all gone out for whatever reason. Please go back to where we were. Hello. Please, can we? Yes. So out of our 39 hospitals and polyclinics, 16 have only one pharmacist at the facility, which is having a serious impact on the quality of pharmaceutical care. A similar scenario occurs with pharmacy technicians, where a lot of the districts do not even have one pharmacy technician. But then I would want to concentrate on the NOP, where we have 70 networks in the region, and out of the 70, 32 of them do not have pharmacy technicians. The next regional challenge is unsustainable revolving drug fund. There's misuse of the fund for unrelated expenditures affecting the facility's financial health and ability to pay off RMS debts. Then we have poor GILMIS utilization, where receipt and consumption of commodities on GILMIS remain a challenge in the region due to we've had several meetings, and some of the reasons are bad network, staffing issues where you train staff and they leave. So as a region, we've put in strategies which will be outlined later. But then I want to mention here that we have gone round on GILMIS utilization, and most of these issues of receipts and consumptions are coming from non-medicine orders. All medicine orders are received and consumed. So I think I mentioned before I got here the brain drain of pharmacists, where PharmDs, out of the 41 recruited, 26 out of them are still at post. The rest have all left to greener pastures and even to CHAG. So we'll move on to regional priorities. Can we move a bit? Yes. Our regional priorities were organized sensitization sessions for pharmacy managers on antimicrobial stewardship, which we did this February. We have had support from KNUST and on the antimicrobial focal persons. They did a training session for pharmacy managers, and some of the facilities are now piloting the program. Then 2, train pharmacy technician in charge of health centers on the standards and practice guidelines. What we did last year was to train pharmacy managers. And these pharmacy managers were to in turn train their pharmacy technicians. And this year we are going to train the pharmacy technicians who are not working under pharmacists so that they can also have an input on the reporting format. The third one is include utilization as an indicator of performance for all pharmacy managers on the performance management system. We all know that our appraisals are now being done on the PMS, and therefore pharmacy managers are being encouraged to use this as their means of appraisal. The fourth is to lobby the regional director, acting deputy director of public health, and DDCC to have GILMIS utilization as an indicator of performance for all district directors and MedSoups, and that has also been done. The fifth is performance of districts are projected at RHMT meetings to MedSoups and district directors. The performance of these districts on their GILMIS usage. In Ashanti, I would admit that we have done everything under the sun. The only thing which I have learned from my peers that we haven't done so far as GILMIS is concerned is turning people away from the RMS and not serving them because they haven't consumed and received their orders. That we are a bit reluctant to do. Section 3. So pharmaceutical workforce management, as you can see, for last year, we didn't have any specialist or senior specialist pharmacists coming in, but we had one pharmacist who was posted, reported, and for 2024, but for 2025, we had none. Pharmacy technicians in 2025, we had 2 coming in and they were posted and they were reported. So in all, we had 1 staff being posted and reporting in 2024 and 2 in 2025. Let's move down a bit, please. Can we move on, please? Hello? Can we move on? So on the staff complement for mechanized staff, we have specialist and senior specialist pharmacists. We have 18. The region needs 62, so we have a gap of 44. For pharmacists, the region has 90. The required is 156, and we need 66 more. Pharmacy technicians, the region has 158 at post. The requirement is 376, and we need 218 more. Dispensing assistants, we have 24. Requirement is 199. The region needs 175. So for total mechanized staff at post, we have 290. Required is 731. The gap is 457. Please move down a bit. Yes, just like the director advised yesterday, we will not talk about number required for casual staff, but then the non-mechanized staff we don't have any pharmacist who is a non-mechanized staff. We have 16 technicians. We have 101 dispensing assistants. So total non-mechanized staff in the region is 161. I don't have the financial implications for this, and maybe in my next presentation we can factor that in. So the total number required. Hello. So let's move on to the general clinical service, please. Hello. Hello.
Hi, we are with you. You can continue.
Yeah, I just want you to move up a bit. General clinical service. We have key clinical service indicators. Total number of OPD visits for last year was 7,248,000, and for 2025 was 7,343,000, having a slight increase. OPD visit per capita was 1.27 for both years. OPD visits by insured clients is 5,555,000 for last year, and then 5,542,000. I would want to say that some of the figures here look like a reduction, but some of them were as a result of the withdrawal. Some of them were as a result of the abrupt withdrawal of limbs sometime during the year. Some of the figures were really not the true reflection of happenings in the region. Number of admissions, we have 477,000 for 2024 and 526,000 for 2025. Number of infant admissions, 37,000 2024, 38,000 in 2025. Under 5, 91,000 2024, 93 2025. Total admissions rate 84.52% against 91.54. Major surgeries are shown, minor surgeries having both increased marginally. Total number of patient deaths being 5,866 against 6,419. Death per admission 1.54 against 1.52. Please move down a bit. Then we'll move on to section 5, which is pharmaceutical care. So total prescriptions served per month was 469,980. Average prescription per day was 14,392. Insured clients number insured was 909,608. And the revenue was 28,287,933.55. Non-insured clients 266,000, and the revenue 38,866,277. So we'll move on to interventions. Please, can you move further down? Yes. So on drug therapy problems, please, can you move up a bit more? Yeah. On drug therapy, clinical ward activities, completed pharmaceutical care plans, we had 76.71 for 2025. Before I proceed, I want to admit that this data did not come from all of our facilities. So we are hoping that in our next presentation, we'll be able to get everybody on board. Then drug therapy problems resolved, we had 85.81. Discharge counseling, we had 88.46. Emergency medicines accessibility on the ward, we had 89.99. Then we move on to section 6, which deals with patient safety and quality improvement. Type of medication errors. For prescribing errors, we had 2,760, which accounted for 72% proportion of medication errors, and I'm sure it's the same throughout the regions. Dispensing errors, we had 378, which is 10%. Administration errors, 323, 8%. Others, 376, 10%, accounting for 100% of the proportion of medication errors. And then we'll move on to outcome of medication errors. We had temporal harm, which is 154, accounting for 4%. There was no permanent harm. There was no near-death experience. There was no death. So in total, we had 376, which is 100%. Source of adverse drug actions. Cardiovascular systems accounted for 59% of our errors, percentage-wise being 37.1. Anti-infective for systemic use, 37 of our errors, accounting for 23.3. Nervous system, we had 13, accounting for 8.2. Antiparasitic products, we had 8, accounting for 5%. Alimentary tract and metabolism, we had 8, accounting for 5. Musculoskeletal systems, we had 5, accounting for 3.1. So in total, we have 159 errors, which is 81.7. I want to add that okay, let's move on to the outcome of adverse drug reactions. So number hospitalized was 15, recovered. For the number hospitalized, it was 15, 18 recovered, 2 yet recovered, 5 unknown. Inpatient hospitalization, 18, 8 has recovered, 10 not recovered. And then significant disability and incapacitation, 1. And the person has recovered. Congenital abnormality, we don't have any. Life-threatening, we had 8, 5 recovered. And then death, we had none. So in total, we had 42. Please, let's move down a bit. Okay, so on rational use of medicine survey indicators, the average number of medicines per prescription for 2024, it was 1.84, and in 2025, we had 2.77. Percentage of medicines prescribed by generic name, we had 90.54 against 96.15. Percentage of prescriptions with written antibiotics. Last year, 2024, sorry, we had 27.11. 2025, we moved up to 41.3. Please move on. Percentage of prescriptions with injections, we had 8% in 2024 and 12% in 2025, which are both good. Percentage of medicines from the EML, we had 89.3 in 2024, 94.68 in 2025. Percentage of medicines from the EML is just a repetition. So we'll move on to the consulting indicators, and average OPD consulting time was 3 minutes 59 seconds. Average dispensing time OPD was 177.8 seconds. Percentage of prescribed drugs that were dispensed, this is actually 88% and not 88%, and that will correct. Percentage of drugs adequately labeled was 88.1%. Percentage of patients with knowledge of correct dosage was 83.5%. So these three, Edna, I'll correct them and resubmit. As a region, we have always had challenges with antibiotic usage. Some of the strategies we have used since we realized it has been to have a refresher training on the Drugs and Therapeutic Committee. And therefore, for the year when we had the 27, we had just had a training. All DTCs in all hospitals and polyclinics were very functional and therefore actively working. So after a year, we had an influx of new prescribers who were coming in, and therefore the picture changed a bit. What we have decided to do, we'll talk about in a way our next steps. So we'll move on to section 7, which is pharmaceutical supply management and financing. So for 2024, under framework purchases, we did 16 million. And for 2025, we did 28. Non-framework purchases, we did 55 million for 2024 and 56 for 2025. So total purchases being 72 million for 2024 and 84 for 2025. Annual sales was 86 million for 2024 and 98 million for 2025. Total receipts for 2024, 70 million, and 2025, 88 million. Payment of vendors, we did 65 million, 2024, 83, 2025. Debt recovery rate, 85% for 2024 and 90 for 2025. But then, Apenting educated me because we did the calculation ignoring the outstanding debt, and therefore we would factor that in our next presentation. So move on a bit. Summary of operations at the RMS. Closing stock at the end of 2024 was 22,500,000 against 33 million in 2025. Cash book balance was 22 million in 2024 and 11 million in 2025. Total creditors was 35 million in 2024 and 41 in 2025. Net worth in 2024 was 80 million and in 2025 was 102 million. Then key medicine availability 2024 was 80, 2025 was 81.4. Please move on. So in the debtor shadow by facilities, we have our hospitals and polyclinics having 39% of our debts. Health centers have 48, CHIPS have 11, summing up our debt to 98. And the percentage being 100. I want to say here that our debt to net worth, our debtors figure is not higher than our net worth, like Director mentioned yesterday. Our debtor figure, though high, our net worth is higher than our debtor figure. And I also want to mention that the region has met individually DHAs having the CHIPS and health centers who are OEN. And one realization that we saw was that some health centers for some accreditation issues have been serving NHIA patients for 2 years, and they have not been reimbursed. And these health centers are still assessing commodities and serving NHI patients because we cannot deny them of service for that. I mean, we deny the people in the catchment area for that. The regional director has taken it up, though these health centers and DHAs, through the support of the regional NHI person at the region, have already written to the NHIA. The regional director has taken it up to follow up on that as well. And I would say that those health centers are quite a number, and they account for a bit of our standing debts at the health center and CHIPS. Next. Please, can we go down? So, analysis of pharmaceuticals by class and value ATC classification. We have alimentary tract and metabolism accounting for 3% of purchases for 2024 and same for 2025. Blood and blood forming also accounted for 2% in each instance. Cardiovascular system, same. Dermatological accounted for 7 in both instances. Genitourinary tract accounted for 12. Histamic hormonal preparations, 10 in each case, and anti-infective systems accounted for 1%. Antineoplastic and immunomodulating agents were not bought by the region. Shall we move on? Can we move on, please? So we have nervous system. In fact, when you look at it, you see that not much changed so far as the percentage purchases were concerned on the ATC. Let's move on. I've mentioned our net worth already. So we'll move on to section H, which are achievements, conclusion, recommendations, and next steps. So in our achievements, we have trained all pharmacy managers on the standards and practice guidelines for pharmaceutical services and shared the manuals as well. We have also trained on as a region, we don't just pick on new pharmacy managers and let them off to go and work. When you are appointed or as a pharmacy manager, we train and orient you for 3 days before you start working at the new facility that you are going to, and that we did this year. And then operationalization of the Regional Medicine Information and Pharmacovigilance Office, which we have captioned RMIPO. We have a designated office which is being manned by a specialist pharmacist in public health. And that office is more or less responsible for collation of pharmacovigilance reports, medication errors, and then we move in to support facilities that are having difficulties in any of these reports. At a glance, as a region, we know which brands of our medicines at the medical store is giving the most ADRs. And in consultation with FDA, we are able to alert FDA on the developments and the brands, and then FDA picks it up from there. We are creating awareness on our Medicine Information and Pharmacovigilance Office, and this we have been doing by going for radio awareness on we're having radio, going for radio programs, educating the masses on the proper use of medicines. We have been going to churches and all, and that is making pharmacy practice known in the region. Then collation and analysis of our ADR reports at the regional level by the units, which I've mentioned already. Then we have formation of DTC and training of DTC members for all newly established hospitals. I mentioned that we had an addition of new hospitals, and these hospitals, the regional pharmacy team moved in to form the drugs and therapeutic committees of these hospitals and train them so that they can start on the right foot so far as medicine management is concerned. We have agreed institutional strategies and procedures to address medication errors. So I'll move on to the RMS production unit. We have added household cleaning agents like liquid soap, sodium hypochlorite solutions to our production lines, and these are being picked up by the hospitals. We have purchased new equipment, reverse osmosis machine, capping machine, and filling machine. So our production unit, effective last year, is fully automated. We have fully automated our production line, and that is one achievement. And then we also are producing purified water for use for reconstitution of our medicines at service delivery points. We produce this and bottle in 5-liter gallons, and pharmacies pick them as and when needed to aid in the reconstitution, taking out all the sources and different brands of waters that are being used for reconstitution. Please go down a bit. Please, can you go down? So in conclusion, I'll say that 2025 showed a marked improvement in the scope of documentation of pharmaceutical care reporting, as evidenced by the second quarter reports received. The region's clinical impact is evidenced by the successful resolution of over 4,690 medication-related interventions. However, the year was tainted with the loss of access to vital documentation with the sudden exit of the LIMS software and critical challenges in human resource stability, as well as the financial sustainability of the revolving drug fund at the facility level. Despite these challenges, a strong foundation has been laid for greater impact in 2026. So on recommendations, 1, workforce stabilization and development. Urgent recruitment to address the staffing shortfalls in the region is needed. Execute the 2026 priority to train pharmacy technicians in charge of health centers on the standard and practice guidelines. Financial and supply chain integrity. On Gilmes optimization, provide targeted technical support to facilities struggling with utilization to improve commodity tracking and data accuracy. Maximize the use of newly automated production line to offset the decline in serial production in 2025. In 2025, when we were putting together these new equipment we bought, we had to break off production for a couple of months, and that affected our production levels. Implement strict regional monitoring to prevent the misuse of RDF for non-pharmaceutical expenditures, ensuring facilities can settle their debts. 3, clinical excellence and patient safety. Rational use of medicines, antimicrobial stewardship. Conduct operational research into the appropriateness of antibiotics prescriptions to validate or otherwise increase antibiotic prescriptions in the region. When we look at the efforts we have been putting into the antibiotic use alone in the region, there are times at pharmacists we want to know if in reality or as a region we are okay with the 20%, or maybe there's a fundamental need that is taking us above the 20% mark that WHO has set. And therefore, we wanted to go into an operational research to check on appropriateness. When antibiotics are prescribed at the hospital level, are there labs that are suggesting it? Are there dosages that are given? Are there, so that will satisfy our curiosity on that. And that is what, that is what the operational research is about. Launch the proposed sensitization of AMS sessions for pharmacy managers, which we have already done. Infrastructure improvements. We want to lobby because in our last round of supportive supervision, we realized that most of the facilities do not have counseling rooms at the pharmacy unit. So we are lobbying for creation of designated counseling rooms within the pharmacy, and also the procurement of specialized pharmaceutical fridges and monitoring tools, such as room thermometers and hygrometers across all hospitals and polyclinics. Next steps. Can we go down a bit? Please, can we go down? So in our next steps, we are lobbying for appointment of district logistics focal persons, pharmacy technicians or pharmacists to oversee all logistics issues, including GILMIS in the districts. And that we have done. We've had our first meeting with them. Lobby for additional pharmacy workforce like all the other regions. Continue to advocate for the procurement and use of pharmaceutical fridges, room thermometers, and hygrometers in our pharmacy stores in all polyclinics and hospitals. Continue to advocate for designated counseling rooms, like I mentioned. Continue sensitization on antimicrobial stewardship program in the region. In fact, we have 2 of our big facilities who are starting the piloting of the AMS. Solicit support to conduct operational research into the appropriateness of antibiotic prescriptions in the region. On this one, I see that we have a large audience on this Zoom meeting, and therefore we have developed our proposal for this research. And like I have mentioned here, we are soliciting for support. So those who are working with organizations who may be interested in this, our research topic, will be most grateful to submit our proposals to them. Can we go down a bit? I'm not too sure if I'm done. Can we? Yes, I think I'm done. So on this note, I'll say thank you to my pharmacy managers in the region who have really given a lot of support. I also want to mention especially Farm Elizabeth Damilda, who is a public health specialist pharmacist at the Regional Medicine Information Unit, as well as my data, the pharmacist in charge of pharmaceutical data, Paul Fletcher. Thank you very much.
Hello. Thank you very much, Chief Rita. That was quite extensive. Thank you very much. The whole team, Ashanti team, we are grateful for your hard work. Please note down your questions, your comments. We'll be opening the floor after this last presentation for this batch, and the next presentation will be Northeast. I know you're ready, so just a minute and then your presentation will be on. Are you sure? Hello, please, you are on Northeast Farm Justice.
Okay. Good afternoon. Please, can I be heard?
Yes, you can. You're loud and clear.
Oh, okay. Good afternoon, Director. Good afternoon, senior colleagues, and every other person present. My name is Justice Derry Kakuano. I am doing this presentation on behalf of Team Northeast region. So to start with, our total population as a region is, I think it's an error. It's about 770,373. So the figure here is an old figure that we mistakenly captured. So the corrections will be done and then the form resubmitted. Okay, so the region has 6 administrative districts with about 29 sub-districts. In terms of the regional hospital, we do not have a standardized, should I say, regional hospital as I speak. But then, by virtue of the fact that the Walwali Municipal Hospital is the biggest in the region, is currently playing the role of a regional hospital. So we have one, and then we have 4 other municipal industry hospitals with 6 private hospitals and polyclinics. And then we also have 5 faith-based hospitals and polyclinics. Then please calm down. Hello. Okay. Yes. So in total, we have about 198 health facilities. This excludes the OTCMS because I'm yet to get data from the Pharmacy Council and the Food and Drug Authority. But I must say that we have about 9 retail pharmacies which are also contributing to service delivery in the region here. In terms of governance and leadership, these are some specific challenges that are very peculiar to the region, even though the list is not exhaustive enough. First of all, we do not have a medical stores, and then we also lack, in fact, I must say, the only region among the newly created regions that is yet to have an office complex for its senior managers and the other regional health director staff is Northeast region. So we are still living in a rented apartment and then getting offices for all senior managers and other colleagues, including that of the chief pharmacist, is quite problematic. So most of the time you go to the office there and then there's no place to sit. That is actually worrying because it doesn't make pharmacy visible enough at the regional health directorate level. To add to that, the fact that we do not have a substantive regional chief pharmacist is also quite troubling. But most of the times, they do things and then by the time you realize either pharmacist is left out or something like that. And then just on a lighter note, when you want to make further comment, then they'll tell you that, oh, because of your absence, we forgot of you. So this is quite a challenge. In terms of priorities, like I said, we do not have a regional medical stores and then office complex. And then critical on that list is the fact that we do not have enough pharmacists and then pharmacy technicians. And then there's also poor pharmacy infrastructure. Let me say that as we speak, we have only 1 practicing pharmacist as far as Ghana Health Service is concerned in the Northeast region. And that is the person of Victor Afriye, who is the senior pharmacist at Walwali Municipal Hospital. The other pharmacist we have is operating from Baptist Medical Center, which is a CHAC facility. So the issue of pharmacy HR is a big problem to us in the Northeast region. So we have only 1 specialist pharmacist, and then in 2025, no pharmacist was posted to the region. In terms of pharmacy technicians, well, the 25 that you are seeing here is an old figure. So the whole of 2025, no pharmacy personnel was posted to the region. In terms of the mechanized and then the pharmacy staff complement, we have Okay. So the number required for senior specialists, and the specialist pharmacists is 8. And then we have 0 at post. 0 at post because the only specialist pharmacy we have has taken up a management position and then is currently not practicing as a pharmacist. So that leaves us with a gap of 8. And then in terms of pharmacists, we need about 16. And like I said earlier, only 2 at post, one at the Wale Hospital and then one at Baptist Medical Center. So there's a gap of 14 there. In terms of pharmacy technicians, 80 are needed for the region, with 17 currently at post. And then, I think this one is an error. So the gap should be more than 17. In terms of dispensing assistant and MCAs, we need 20 with 0 at post and then 20. The 20 here is actually, well, I say there. Please, can you move forward? Can you go up or so that I'll say something? Okay. Yes. So the 20 MCAs is actually the gap because these are people who are already working at various pharmacies and then drawing salaries from the meager hospital IGF. And then, so if, I mean, steps could be taken to recruit and then get them mechanized, that would be helpful. And then, so in terms of total mechanized staff, we have about 102 as the gap as far as Northeast region is concerned. Please move on. Okay. For the non-mechanized staff, we have a total about 15 total non-mechanized staff as we speak. Please move on. Okay. For general clinical services, the region recorded an increase in OPD attendance in 2025. And this has led out to an increase in the OPD per capita from 0.65 in 2024 to 0.67, with more clients also, more NHI clients also visiting our OPD. And then we also recorded a low number of hospital admissions, including under 5 admissions, and that eventually led to a total hospital admission rate of 56% compared to the 61% we recorded in 2024. Total major surgeries in 2024 were 2,576. This has seen a slight decrease. In fact, this is not slight, I should say. It has seen a decrease to 2,643. However, there was an increase in the total minor surgeries from 2,491 in 2024 to 3,565 in 2025. So the total number of patient deaths also saw some slight increase from 962 to 992 in 2025. And that leaves us with a death per admission rate of 2.2% in 2025. So for pharmaceutical care, the total prescription served for the whole of 2025 was 31,234, with an average prescription served per day being 1,042. Unfortunately, we couldn't get data for the other information. Please move on. Please move on. Okay, so in terms of our RUM indicators, please move on. No, this is a drug therapy programs. Okay. So in 2025, we had 4.8. Please come down small. In 2025, we had 4.8% of drug therapy problems that were resolved. Unfortunately, we couldn't get data for 2024. And then we also have 4% of our patients who got discharged being taken through some form of counseling before they got discharged from the various facilities. And that gave us, with an emergency medicine availability at the various emergency unit being 30%. So in terms of patient safety and quality improvement, the region also recorded 50% of prescribing errors. In fact, almost all our quality issues had to do with prescribing errors. And this happened because every now and then we get new clinicians, especially the PAs and then the other medical officers who are taken on a local basis. They come with their own way of prescription. So most of the time, you realize that almost all the medication errors are coming from that. And then we have some few dispensing errors, representing about 8.2%, with the drug administration errors taking 6.6%, and then the others 35.2%. So what were the outcomes of these medication errors? In fact, 98.5% of them did not cause any harm, with only 1.5% causing temporary harm. The rest of them, in fact, there was no death. We pray against that. And then there was also no permanent harm to any of the clients who were exposed to these medication errors. Please move on. Okay. So these were the source of the adverse drug reactions. We have 17% coming from the alimentary tract and the metabolism, with 10% coming from blood and the blood-forming organs, 19% coming from the cardiovascular system, 6% coming from dermatologicals. Please move on. 8% from genitourinary system and the sex hormones, and then 40% from anti-infective agents. And the outcomes of the adverse reaction. Okay. All right. Unfortunately, we couldn't get data for this particular session. In the rational use of medicine survey, the region recorded 3.5 average number of drugs prescribed per prescription, which is an increase from 2.7 in 2024. This is actually a worry because at the last review meeting, it came up for discussion. And then the regional director has tasked myself and the deputy director of clinical care to look into it and then see how we can intensify our supervision monitoring to the facilities, as well as strengthening of the drug and therapeutic committees, so that we'll be able to help reduce this figure. And then a percentage of medicine prescribed by generic name also saw a slight decrease from 103.5% in 2024 to 95.5%. And then the percentage of prescriptions with written antibiotics saw an increase from 30.8% to 39.8%. The percentage of prescription with injection also increasing from 9.8 to 14.4%. And then the percentage of medicines from the essential medicine list was 93.9%. Unfortunately, we couldn't get data for the other indicators. Please move on. Okay. As at the time of submitting this this report, the data on the this was not. Please go forward, go upwards, and let me see something. Okay. All right. Yes. So we did not have data on that one because we do not have a medical store. So you realize that our tracer medicine availability is the same as that of Savannah region and the Northern regional medical stores. So that gave us 51.8%. So our data schedule by facilities. You realize that the DHAs which manage the health centers and then our chiefs constitute a chunk of our RMS, our indebtedness to the regional medical source in Tamale. And that figure is about 45.3%. This is something that is very worrying. Yesterday, I listened to some of my senior colleagues present, and then this issue came up, and it has to do with the fact that we do not have the pharmacy personnel at the sub-district and then the facility level, especially when it comes to the chiefs and the health center. And this is having a serious effect on medicine availability, and then by extension, revenue generation, because once they are available without anybody monitoring it, I mean, either they allow them to expire or they sell them and pocket them and all sorts of things. So it's really a big problem. So we also have non-Ghana facilities taking part of our RMS debt with Zipline specifically contributing to about 1,500,000 Ghana cedis as part of the Northeast indebtedness to Northern Regional Medical Stores. The other facility that also takes about 8,000 or so is coming from the CHAC facility. Okay, please move on. Okay, we do not have data for this. Please move on. So so despite all these numerous challenges that I have enumerated, the region was able to carry out some capacity building workshops for the year 2025. Notable among the trainings was a standard practice and then standards and practice guideline for pharmaceutical service. We also did a training on the drug and therapeutic committee, rational use of medicines, as well as a snake bite management, and then rational utilization of ASB and ARV in the course of the year. So to conclude, I want to say that the Northeast region continues to lag behind other regions because of the lack of resources, including the human resource and the financial resources. That's making it very difficult to attract and retain pharmacy personnel. So as part of our recommendations, we are proposing that there should be a deliberate and a conscious effort by headquarters to post pharmacy staff to the region. I say this because when you leave it open, they will prefer to be in Tamale and Bolga and other bigger towns, because Northeast region is basically a rural region, and for which reason most staff are usually not interested in coming to. So there was that deliberate and conscious effort to post them to Northeast region. And then we are also proposing that the regional health directorate and the Ghana service in general maybe can make it mandatory, just like we did with the medical officers. Should be mandatory that we should develop and then put in place some special motivational packages to attract and then retain them, so that when they come, they will feel at ease and will not want to leave the region. So next steps, to continue to advocate for recruitment of pharmacists and pharmacy technicians to the Northeast region, and then to also continue to advocate for support to create regional medical stores, and then to intensify our supportive supervision visit to service delivery areas. On that note, I say thank you very much and over.
Thank you, Acting Chief Justice. We really appreciate you holding the fort all this while. Thank you to Team Northeast. 2 pharmacists per region. That is serious. Gospel members are only 2 in the whole of Northeast. I'm even surprised you were able to come up with this report. We really appreciate your efforts and your hard work. Thank you. Okay, on that note, please, I'm opening the floor for questions, contributions, commendations. Dr. Hedido, we've seen your comment, but if it's possible for you to speak up, we would like to hear your voice. And
hello, can you hear me?
Yes, we can.
Oh, okay, thank you. Sorry, I joined in late yesterday. I joined in late. I'll start by congratulating the director for this initiative. I think it's a good one, and as you can see, a lot of things have been done in the region. I've posted some of my questions in the chat, just a few. Somebody mentioned marketing of what we are doing, which I think is also very key. Visibility is key for people to know what you are doing, and probably in the future, maybe we look at how to market this thing that you're doing as a workshop for people to see what pharmacy is doing and then also push it up. And then these are general comments, and I'll ask one question. That'll be it. And then I've also want director, if we can also look at pulling 1 or 2 indicators across the region, which will be somehow linked to what is happening now, maybe from hospital pharmacies, We have the Mahama Cares, there's NCDs, data visibility issues, health promotion, AMR. I can see that most of you are beginning to do things on AMS, AMR in public, primary healthcare, and so forth. If we can link one or two indicators to any of these initiatives so that it will be trumped as probably hospital pharmacy contribution to those initiatives also. And then for the tables, where we are doing the comparison, it would be good we add the percentage change on the right side so that visually we can easily look at through and then see where the ups are coming and then the downs are also. And my last thing is I can also see that there is an increase in specialist pharmacy sort of when you look at and that would mean that the top in terms of the cadence is also going to be going high. It's interesting to see that there's a shortage of pharmacists across the whole country. Though there are a number of schools and the numbers are being churned out. I don't know if this data that we have received will put together some form of maybe a concept or position paper to be submitted to advocate for recruitment. And I'm also saying the top is also going to be heavy and we need to show work for it. I went around one or two facilities and there is this report looking at can't remember exactly, but I could see there's a doctor population ratio, but there's nothing for pharmacy. And with this data we are seeing, I think something can be crafted through that and then also used to advocate for pharmacy recruitment. Those are the comments I have. My questions are already in the chat box. And then maybe one or two responses will do. Thanks and for the good initiative. I think it's a good thing and we hope to see next year what happens. Thank you. And over.
Thank you, Dr. Hedidor. We appreciate all the comments. And for Dr. Hedidor's questions in the chat, I will read a few. To Greater Accra, he's asking, what is accounting for the poor Gilmes utilization and poor antibiotic use indicators? And then to Greater Accra again, he's asking, is there a difference between net worth and working capital? You gave different figures for both net worth and working capital. Okay, and to Ashanti region.
That question is from one Oku Abena Okai. He has that question, not for me.
Yeah, that question
That's
is okay. Thank you. But I think another comment you made was, aside Ashanti, who mentioned pharmacovigilance to explain a point, it appears it is not part of the reporting. Thinking it will come after medication errors, think we need to look at this if possible. Okay, WHO values the pointers, and we need to look at the facts behind the figures where needed. Hence, I agree with the operational research suggestion. Okay, I think that is all from you. Okay. So Greater Accra, I hope you've taken notes so that you will respond.
Yes, please.
Okay. Esther is asking whether the recorded version will be available. Yes, it is available. Even yesterday's one is already available. I will let Dr. Owusu let us know how to get access to it. Okay, there was another comment by Dr. Hedidor that says, if dispensing is less than 2 minutes, do you carry out counseling as part of the dispensing? 2 minutes is quite a worry for me, noting you have to educate the patient. And this comment was supported by Antimata, who also said she thinks so too. So the 2 minutes, we might have to revisit it. Jemima is saying she totally agrees. The reintroduction and reinforcement of the district pharmacy concept is a step in the right direction. Okay, so thank you all for the comments in the chat. I see 2 hands raised, so I'm calling you, Bob Hayford. After that, I'll call Memory.
Oh, thank you very much, Director. Please, my concern is about Northeast, where they have only 2 pharmacists working in that new district. I want to take this opportunity to appeal to our directors on board and then our chief pharmacists on board. See, when you post pharmacists to now, when we didn't get the clearance to have about 1,000 pharmacists to post to various places, you can have those who are in the deprived district. Sometimes you see it as a deprived district, but the standard of living over there is very expensive. Accommodation very expensive. So the pharmacist will be posted to the facility. He gets there and then see that the salary and then the condition of what we call standard of living over there will not be suitable for him. So he will leave to these private facilities like maybe the Repping and then other places. So I'm taking this opportunity to plead to the director, if possible, we can get a letter or lobby from the Director General to get support for pharmacists and then pharmacy technicians who are posted to these deprived districts for support. Sometimes with only the accommodation, we are asked to lobby from our own facility. Sometimes we will lobby, but in management, where you have other management members, it becomes difficult for some of them to accept supporting or helping your junior pharmacists or your junior technicians who have come to those places. But if there's a letter which is there to support them, like how the medical doctors they do, when they are about 5 and even they are posted in the district, they ask them to be supported with tenant accommodation. So I'm pleading that if we can also lobby that, it will help other pharmacists and then other technicians being posted to the deprived district. Thank you very much. With Northeast as my reference. Thank you.
Thank you, Hayford. Yes. Chief Memory, please.
Okay, thank you, Madam Edna. Let me start from where my brother left off. I think that to resolve this issue of pharmacists, recruiting and retaining pharmacists at the various districts, a lot has to do with what he said. The letter that is given to pharmacists to be posted to various districts or hospitals, even most of the times, like you are posted to the district director, and now it's like you are now seconded to the hospital or so. And the letter actually does not give you any opportunity, any chance to even be able to fight for anything. So everything is left for the hospital management to decide either to help you or not to help you. If we can change that narrative, I think it will help a lot. My brother said it all. These days, the so-called, sometimes you feel that when you move into the district, maybe food will be cheap or something. These days, it's rather the reverse. Living conditions there are not cheap at all. So it makes it very, very difficult, extremely difficult. But I have some 2 points for Greater Accra. I hope the lady is listening.
Yeah, please.
The pharmaceutical care. Hello?
Yeah, please.
Hello?
I'm here.
Pharmaceutical care. I don't know whether I'm not getting it right. But with regards to your total prescription served per month, and then average prescription served per month, looking at the figures, I thought there's some challenge with it, because you are talking about the entire region. And I don't know, But my view is that you need to look at the figures again, because the entire region, the figures that were presented were like one hospital figures. So we need to look at that. If at that portion we projected, I would have been very, so the world see exactly what I'm talking about. Also, also rational use of medicines. Again, the average number of drugs per prescription, I don't know whether it's a typo or so what. I saw something like 21 point something. So I think that one too we need to revisit and look at it carefully. And I will conclude by revisiting the issue of dispensing time. From the comments that I'm hearing, it means we have to relook at the WHO survey method and the criteria that they gave us. Even in this document that we are looking at, Madam Edna and Director, I think you have put the targets. So if these are not satisfactory, then we have to re-look at the survey and adjust accordingly. Thank you.
Thank you. Yes, on that issue will be revisited by all of us. We will see if we will still go by WHO's standards, or we will modify it to suit our situation. So we will revisit.
Sure.
Yeah. Yeah, Greater Accra, I think there are a few questions for you to answer, so we will let you answer before we will call for other questions.
Thank you very much for the questions. Just to start with the last question that came, that is the figures. That is documentation challenges. I think during my presentation, I mentioned it. And also, it's not all the hospital that has also reported on that. So we'll look at that and revisit that one and update it. So that is for that one. And then with the GILMIS, poor utilization, it is about poor attitude. Because for Greater Accra, our RMS is open every Friday for refresher training, which we do every Friday. And even facilities that need our support, we also go to the facility to support them. And others also give the excuse of data, but surprisingly, they get data to order. But when it's time for them to consume and receive, they give an excuse of data. And also, it's due to the high attrition rates. You train them, and then the next time you realize they have been moved. But I think with those improved features now on GILMIS, the data or the utilization will go up. Because now, if you don't receive, you don't consume, you cannot place the order. So that one is for the GILMIS part. For the DTC, for the antibiotics use, actually, there was a marginal increase, although we were not able to achieve the 20%. But I will encourage or task my managers to orient the new prescribers that come into the system and also share their RUM findings monthly during their clinical meetings. Yes, about the difference in the net worth and then the working capital, yes, there are two different things. When we talk about the net worth, it includes all the total asset and then the total liability. But when we are talking about the working capital, so all the current assets less the current liability. Thank you. I hope I've answered the questions. Hello.
Hello.
I hope I have answered all my questions.
Yes, you have. Thank you, Dr. Gifty. And you've confused us. So I think that issue on net worth and working capital too is something that we will revisit and educate ourselves better on, so that we are all on the same page. There are two schools of thoughts currently, so it's something we've taken note. That one, and then the dispensing time will be worked on, and then we will educate ourselves about it.
All right. Thank you.
Thank you. All right, please, the floor is still open before we move on to the final batch. If there's any comments, please, let's hear you. HP, please, you can unmute and speak up.
Yeah, thank you very much, Sister Edna. I just want to comment Farm Gifty. I know she's just acting and she's doing well. I just want to commend that she should keep on the good work that she's doing. Thank you.
Hey, Chief Fellas, we hear you. Farm Gifty, well done. Actually, it's not easy when you are put in that position. From the outside,
Thank you very much.
I see Mrs.
Thank you very much, and thank you for the opportunity to. I really appreciate it. Thank you.
All right. Farm Elizabeth, please unmute and speak.
Good afternoon, Director, and as all our senior colleagues, everybody else on the platform. I would like to congratulate all the chief pharmacists who have been able to present so far and acknowledge the good work they are doing in their respective regions. I have something that has been on my mind for a period now concerning the antibiotic prescriptions in the RUM surveys that traditionally has been used as a pharmaceutical indicator. I am rather of the view that it is a purely prescribing indicator. And so while pharmacists may do all they can to try and reduce antibiotic use, because it remains in the purview of the prescriber to write, it may be one of the reasons why we are having this challenge. So long as it remains on the face of the prescription, whether or not eventually the medicine was handed to the client, it still remains there. And therefore, when we do the survey, it will still be picked up. I am thinking that collectively we should think through this and see the best way forward. Thank you.
Thank you, Farm Elizabeth, but what would be your recommendation? As for it being a prescription indicator, that is very clear. The rational use of medicines indicators, we have the prescribing indicators, then we have the dispensing indicators, and then we even have the patient's indicators. But for a while now, the country focuses mainly on the prescribing indicators. Now we have also added the dispensing indicators, which is in our purview. That is directly related to pharmacy practice. But it does not negate the fact that we still have to collect the traditional prescribing indicators, which are the traditional 5 we've been collecting. But with your submission, what will be your recommendation? What are you recommending for us to do?
Okay, thank you very much, Dr. Edna. My recommendation would be that we should be pushing for this to be handled more by the professionals that actually do the prescribing. And so if during their appraisals or the performance management systems, this indicator is given to them, so via the clinical care, the Deputy Director Clinical Care, it is given to the med-subs and then passed down to their doctors, we will make much more of a headway rather than always looking like it is pharmacists who are spearheading this. There's only so far we can go. So yes, while we may continue to collect the data, but let's also try and engage so that we focus on what our own indicators are: pharmacovigilance, medication errors, dispensing time. Those things are purely pharmacy. And then the ones that we need to collaborate, let's make sure that we are collaborating properly with them. Because in my small experience, I have noticed that a lot of the time it ends up on pharmacists' appraisals, but you go to our counterpart doctors and it is not on the appraisal. Thank you.
Thank you, Fam Elizabeth. These are the things we would like to discuss during the open forum. So please don't log off. We will have the forum and we will discuss. But I will give the opportunity to Dr. Hedido to make a brief comment. But please, Dr. Hedido, Elizabeth, and everybody on call, please do not log off after the next set of presentations. That's the key part of this year's performance review, the open forum. So please hold on for that. But Dr. Hedy.
Yeah, sorry, I don't know if I may be staying on for long, but with the issue of the RUM, as I did indicate that they are pointers, as she says, they are indicators. So we should also be going, we've set a value for which we are trying not to go beyond. But if we are going beyond it, what's accounting for it? That is where we need to go behind the figures. Imagine that a prescription like with 10 drugs. Yes, for business reasons, somebody may do that. But you, the pharmacist, you are the gatekeeper. For a prescriber, he's writing. He's writing. So, and it should not stay on the pharmacy report alone. That is why we have this feedback. Once we do that at the DTC meetings, management meeting, you are supposed to present that to the prescriber. So that if there's something they are doing wrong, then they have to then what correct it. For the appointers, they are indicators for you to see that we are, and they are even for quality checks. We are going beyond a certain level. What is accounting for that? Can we go back and look at it? The dispensing time, as I mentioned, 2 minutes, yet it's 120 minutes. But the question is, if you give me a prescription and I vet, it goes through the whole system and it comes back and I have to do that under 2 minutes. Then it tells me I'm doing the old thing that we used to do. Take this 3 times daily, take this 2 times daily. We have not educated the patient. So those indicators are checks on our work and even within the drug use system. That is what I want to put across. Thank you. And of course, the director can decide to have readapt the whole indicator system and see how best it can respond to our setting. Thank you. Over.
Thank you, Dr. Hedido. Thank you all for your contributions. So on that note, we will move on to the last set of presentations. So we're beginning with Volta region. Volta, please, are you ready? Volta region, please, are you ready? Okay, Upper East region. Upper East. If Upper East is not ready for now, can we move on to Eastern region? Please, is Eastern region ready?
Yeah. Yes, I'm ready.
Okay, please, Chief, please have you sent your thing?
Yes, I sent it. Unfortunately, I couldn't get it on the jot form, but I sent it in the morning. And so Farmer Usu was saying I couldn't present. I don't know the decision now.
So the jot is still not ready, right?
It's not ready. Yes, I have to find time and do it. I missed that announcement. So what I sent is a PowerPoint.
Just hold on a minute for me.
Very well.
Chief Aubrey.
Yes.
Yeah, please, you're on.
Okay, so next slide.
Please, you have 20 minutes.
Very well, I'll try. Next slide, please. Yes, so this will be my presentation outline. Next slide. Yes, so we have a total of 51 hospitals and 1,237 health facilities in total. The sub-districts, we have 225 with 4,184 communities. Next slide. Next. Yes, so all pharmacists and technicians were appraised for the year under review. We had 8 pharmacists being promoted and then 10 technicians also being promoted. Next slide. Yes, this were the trainings that various pharmacists went through during the year under review. We had an EMS training organized by WHO. Dr. Hedido was very instrumental here. And the others are pharmacovigilance, ART service delivery, drug and safety monitoring, and also the SPGPS, which was done at the regional level and also at the downstream. Next. Next. Yes, OPD attendance increased less than 200,000. The OPD visit per capita increased a bit. We have OPD visits per insured clients almost at the same level as 2024. And I must say this constitutes about 75% of the total OPD attendance. Major surgeries went up slightly, and so was the minor surgeries. Next slide. Top 10 causes of OPD attendance. The first 3 for the year 2024 and 2025, they maintained their position, being malaria, respiratory tract infection, rheumatism, and other joint pains. Rather, the top 5, they stayed the same. The figures for 2025 were either slightly lower in the case of rheumatism and other joint pains. For malaria, it inched up a little bit. It was the same for respiratory tract infections. All other diseases constituted about 34.3%. Next slide. Can you go back a bit? I'm at OPD admissions. Yes. So malaria topped the OPD admissions, followed by UTI and hypertension. There were changes in position 4 and 5 when you compare 2024 and 2025. The figures are close. Next slide. Pneumonia topped the list of causes of mortality with 6.8%, followed by stroke and essential hypertension. Next slide. Yes. So this is a 3-year trend of patient discharge counseling that was done at the regional hospital. 2023, we had 0.4% of the total admissions being counseled. It went up a bit in 2024. The 2025 figure is lower because some of the data were trapped in the LIMS. In all, 27 ward rounds were held in the various wards, and also solo bedside rounds were done. Next slide. Next. Yes, so For the medication errors, 2023, we had 24 facilities out of 27 reporting. 2024, it went down to 19, and 2025 was 25. I should have added the number of reports that were generated. In 2023, it was 3,621. It went up in 2024 to 4,314, but it dipped in 2025 due to data issues to 3,967. Next slide. So we looked at the proportion of male and female, that encountered medication error. And if you look at the figures, it looks like they don't change much. It's always hovering around, male around 33%, and then the female around 66, 67. I'm sure this aligns with the national population of the sexes that we have in the country. Next slide. Can you come back a bit? One slide back. Yes, the age group. So we looked at the age groups that were affected. The worrying trend is that we have the highest proportion being above 65 years. And I think this is something that, as a country or as a region, we need to look at. This is a very vulnerable group. And if they are the people experiencing medication errors the most, then we should be concerned. Next slide. So the type of errors, prescribing errors topped as usual with 88.15, followed by dispensing errors and the others. The trend has been the same for the last 3 years. Next slide. Consulting rooms were the locations where this medication errors were committed. For the year 2025, it was 68.7, and pharmacy was 11.5, and the ward 19.3. Next slide. For detection, pharmacy remains the place where most of the medication errors are detected. In filling out the jot forms, I would include that for the consulting room and the wards. Next slide. For the category of medication errors, incorrect doses topped, followed by wrong drug selection, 11.3. This has a direct link to the human resource, the quality and quantity that we have. It will show up again as we move forward. And I think we should be looking at that. Next slide. For the cadre of staff, doctors remain second to the physician assistants, and then this is followed by the pharmacy assistants, what we call the medicine counter assistants. Next slide. Whether the medication error reached the patient or not, for the year 2025, it inched up from 1.3 to 2.0. And then 98% of the errors did not reach the patients. Next slide. Next. So we go to antimicrobial stewardship. The key issues at the beginning of the year were low functional AMS committees in the facilities. The fact that the AMS committee members were not trained in AMS activities. And then the regional percentage antibiotic use was above 30% as at the end of 2024. Next slide. So what were the objectives of the committee? We decided to scale up the formation of functional AMS committees in the district hospitals to about 100%. equip them with knowledge and skills so that eventually they can coordinate their activities and reduce the regional antibiotic use to below 30%. Next slide. These are some of the activities that were carried out for us to achieve our target. An action plan was drawn, shared for all of us to make an input. 1 or 2 meetings were held, quarterly meetings were held in all facilities. Trainings were done, as I mentioned, by Dr. Hedidor and his group. AMS ward rounds carried out with prescribers and ward team at some facilities. Infection prevention and control, IPC and AMR awareness was done for new staff. Distribution of hand hygiene protocols to various units in some facilities. And then sensitization of wards and units on the rational use of antibiotics was done. Next slide. These were some of the other activities. Of most importance was the point prevalence survey that was done at Eastern Regional Hospital. It's still ongoing. They are the data collection point. And also Fleming has a study currently going on at the same facility. We had a very successful WOW celebration across the region. And other activities include radio education, OPD talks on AMR awareness. Next slide. Yes, so despite all these, you realize that for 2025, the antibiotic use went up. And there's a good reason for that. The corporate facilities were all the new hospitals that were opened at the end of December 2024. So I think we need to go down and do more training at these new facilities. So achievements for AMS, about 81% of the facilities now have functional AMS committees. We tease them out of their DTCs so that it doesn't become cumbersome. Once they finish their DTC meetings, they continue with AMS activities as well. It used to be 58.3. The regional training came on, as I mentioned. We had 67 participants. It's a 3-day meeting, very successful. Observation of World AMR Awareness Week WOW across the nation, the region, as I mentioned, and a solid action plan has been drawn, which is guiding our activities. These are some of the challenges: inadequate resources, infrastructure for infection prevention, limited access to diagnostic tools such as culture and sensitivity. Out of about 27 hospitals, I think we only have 10 of them having laboratories. The age-old problem of over-the-counter sale of antibiotics remains, and then resistance of healthcare providers and patients to disease from misuse of antibiotics. Inadequate funding for AMS activities is one of the challenges. The way forward, we're going to encourage 5 more facilities to do PPS, focus on public education, raising AMR awareness, form and strengthen AMS teams in all the 33 districts, provide training for AMS, further educate reduction in the percentage of antibiotic from 37 to 30. I introduced the district pharmacy concept before the network of practice came into effect. And this is where, the sub-districts is divided among the head of pharmacies in the various districts. They have their duty that they perform. But in addition to that, we're going to ask them to do some work with AMR. Next slide. Next. Yes, so if the blue color represents the number of reports that were generated every quarter. And as you can see, it's been going up until we had data issues in the 4th quarter as well. Now, the red or the other color represents submissions, feedback from FDA, and that has not been encouraging at all. We did this just to let them know what was going on. And so far, we've been knocking on their doors, but it doesn't seem to, have any effect. I think we'll indulge the Office of the Ghana, the Director of Health Services, to help us with this problem. So the challenges and way forward, feedback not forthcoming from FDA. We need to train our workers, regular training, and then interactions with FDA at a higher level to get them to give us feedback. Next slide. This is the district pharmacy concept, which / NOP. What you see here, it's visits that the pharmacists are supposed to pay to the sub-districts. They're supposed to be quarterly visits. So excellent. Only 4% of the facilities were able to do 4 visits within the year. 13% did very good for 2020. 20% for 2025 did very good, and then 33% had good performance for the year 2025, and so on. Next slide. Please go back one step. One step back. Yes. So when they go on their visit, they're supposed to look at the conditions, historic conditions of medicines. They're supposed to look at the tracer, NOP medicines availability, and any other thing, help them with their monthly returns, how to, even for them to calculate their net worth, etc. So for the year 2025, 61% of the facilities had 90% and above tracer medicines available. And then 39% had below 89%. RUM. So 20 facilities reported out of 27. Next slide. For average drugs per encounter, inched up from 2.9 to 3.1. Percentage prescription in generic dropped to 96.3. Percentage prescription with antibiotics, like I mentioned, went from 32.5 to 37.5. Percentage prescription with injections also increased to 8.8. Percentage of medicines from EML dropped to 87.3. And the same for diagnosis. And all these have to do with LIMS that was taken away sometime in that year. The next, average consulting time remained almost the same. The average dispensing time went up a bit to 68.3. Average percentage of drugs actually dispensed went up to 92.9. Percentage of drugs adequately labeled went up to 96.2. And percentage of patients with knowledge of corridors also inched up a bit to 93.6. This is for the patient care indicators. Next slide. For the facility indicators, percentage of drugs cost spent on injections was 73.6. Availability of essential drug list for 2025 was 95. Availability of hospital formulary published within 2 years for 2025 was 75 compared to 50 in 2024. Next slide. For the complementary indicators, percentage of patients treated without drugs dropped to 4.8. Average cost per encounter went up to 35. Percentage of drug costs spent on injections dropped to 13.8. Prescription in accordance with treatment guidelines dropped to 79.5. Percentage of patients satisfied with care went up to 95.3. And access to impartial drug information went up slightly from 97.8 to 98.6. Next slide. For the financial side, as at the end of 2025, the user facilities owed the regional medical stores about 72 million. This came from a figure of 64 million in 2024. This is for medicines. And for the non-medicines, it increased from 10 million in 2024 to 15 million in 2025. There was improvement in the debtor days from 334 days in 2024 to 285 days in 2025. However, for the non-drug, there was an increase from 303 days to 323 in 2025. Next. So the net worth for Eastern region is 102,538,086. And this represents 20.2% increase over 2024. Next. So this is the breakdown, the stocks for medicines and the bank balance, creditors and debtors, giving you a net worth of 88 million, whereas the non-medicines is giving you 14.5 million. The total of this is the 102. So this is a graphical representation for medicines from the year 2019 to 2025. And this is for the non-drug consumables from 2019 to 2025. This is just a breakdown of everything that I spoke about financially. Gilmer's utilization, 2023, the order was 93%, receipt was 58%, consumption was 53%. In 2024, it inched up to 93%, and then consumption remained at a move to 71%. For 2025, we have issues with order, the ordering, receipt also dropped, and consumption inched up by just 1%. We have put some measures in place such that if you have not received the items that you ordered, serving you again is always an issue. Just to encourage them to receive everything that they order. So some achievements here. We have been able to expand the infrastructure at the regional medical stores. And as we speak, we will be able to store up to about 6 months. Currently, we can do just about 2 months or so, 2 to 3 months. But now, with this, the completion of the extra space, we can store up to about 6 months. And this was fully funded from the proceeds of the regional medical stores. Perhaps if we had this in cash, our net worth will be over and over everybody here. So there's consistent growth at the regional medical stores. We have the highest tracer medicine availability, successful regional fully funded LMD. We were able to transition smoothly when the stop order came. Before then, we were doing about 25 to 30% on our own before the stop order. And after that, we took over completely, and we'll be able to do all the rounds, the 6 rounds that is expected of us. All planned supply chain coordinating meetings, hospital pharmacy managers meeting, AMR technical working group meetings were successfully conducted. We have a research which on medication errors, 3 poster presentations have been done. One at the recent FIP, one in Scotland, and the manuscript for the research is ready.
Take the medicine.
On next steps, we intend to improve Gilmer's utilization to at least 90%.
Did what?
Equip the newly built RMS extension with shelves and pallets so we can commence its use. Lobby Ghana Health Service for additional pharmacists and farm techs, a problem that cuts across all regions. Lobby partners for additional vehicle for LMD. And continue to strengthen the debt collection activities, especially at the sub-district level. Thank you. These are some of the pictures. We went to visit a World Food Program to look at their shelving and pallet in Accra. And also, this is one typical meeting supply chain meeting, we had the opportunity of staff from SSDM joining us in that meeting. So I'd like to thank my farmers, my head of pharmacies, who have been so supportive, to the work that we do in the region. Thank you.
Thank you, Chief Obriagwa. We're grateful. And it looks like Chief's presentation will be the last we will take for this year's performance review. So on that note, the floor is open for questions for Eastern Region. Questions, comments, contributions, anything anyone want to put across is welcome.
Hello. Yeah, Mohammed, can I come in?
Yes, please go ahead.
Yeah, thank you very much, Chief Obri, for a good presentation, though it varies from all the other presentations. I think it's laudable and very good and very informative as well. I want to find out, you visited the World Food Program in Accra about their logistics and their how they are storing and their warehousing situation. And from that visitation, what actually did you learn, or what were the results, and how has it influenced how you've been managing your RMS? And secondly, too, you said that the LMD, you are now doing it all by the region. But I know in the stop order directive from President Trump somewhere last year, there wasn't a complete stop order, but then some of the items were still lifted by the 3PL. So I don't know whether they are still doing that and you are doing the remaining, or you are still taking everything off their hands and you are doing all 100% by yourself. Thank you.
Thank you, Chief Felix. Please note that question. Oh, there was a hand raised and I was about to call, but now I don't see it.
Yeah, can I come in?
Yes, please.
Yeah, mine is on the medication errors. But first, thanks for the comprehensive presentation. It's interesting to note that the over 65 years are experiencing more errors. I want to find out what could be accounting for this, and any counseling in place. Did it also result in any ADRs from this? Then the next question to you said some of the medication errors reached the patients, of which I'm trying to look at the gap, probably coming from either the pharmacy. So what mitigation measures have been put in place to reduce this thing to zero? Thank you, Anova.
Thank you, Dr. Hedido. Chief Aubrey, please, you may respond to the questions.
Yes, so thank you. The visit to World Food Program gave us an insight to how you can, maximize very limited spaces, with shelving and, other equipment. So we learned the various ways, of putting shelves in the space, and the use of effective use of the forklift. It was then we realized that they even have forklifts that are electrically charged. So they took us through all that. that gave us an idea as to which equipment to buy in order to maximize space at the newly built extension at the regional medical stores. The second one is the LMD. Yes, the stop order was partial. As a region, we did an assessment of the two situations and realized that if we did everything ourselves, we would save cost and things will be simpler for us. So as we speak, since the stop work order, we've been doing it totally by ourselves. Yes. To the other questions, yes, we realized that most of the medication errors were reaching ages above 65. We have not been able to tell why it is so, but like I mentioned, the reason is because of the lack of human resource, the proper human resource, confronting us. And so at the counter, all manner of things are going on. And I think that this information should go out there so that with the limited numbers we have, we can still measure twice before we cut so that such things can be watered down. On the harm to patients, even though the error got to the patients, no harm was caused in all the cases. So there was zero casualty. I don't know if I'll be able to answer all the questions. Over to you.
All right, Chief Aubrey, thank you. I think you've answered all, but just a follow-up to the last one you said. So if you rate a patient, how was it detected? Did the patient come back to the pharmacy?
Yes, I think that most of them were inpatients, and there were some that were able to trace using the details, on the system.
If inpatient, I understand it. Thank you.
Yes.
Please, is there any more question or comment for Chief Aubrey, Eastern Region? On that note, I think Chief, you've done a great job and you'll be discharged for now. Thank you.
Oh,
Thank you.
hello. Hello.
Oh, yeah, Chief IK.
I just wanted to slip in this question small. Sorry for that. With regards to the operations, the LMD operations, comparing what they are doing on their own with the one that USA support in terms of cost input, how would he say which one is affordable per our Ghanaian standards? Or eventually, every region should be looking at self-sustaining because nobody knows what happens tomorrow. What would he say is the way forward economically? Is it prudent? Thank you.
Thank you, Chief.
Yes. So, can I answer?
Yes.
Yes, sir. Yes, sir. Please.
Yes, I think from day one, the word has been sustainability. From our partners, they started with us but every day they reminded us that, hey, we need to prepare for the day that they will pull out so that we can do some of these things on our own. So sustainability has been the watchword from day one. And as a region, we're ready for it. When I took over here, they had just purchased a brand new truck, which became very instrumental when we started doing these things on our own. And then after, we decided as a region that, look, why don't we start taking some baby steps in this area? So we took up 25% of the distribution. And so we were a bit ready when the stop work order came. and then that's it. But I can tell you it's not easy. If somebody is managing your transportation system for you, you go to bed and sleep soundly. But if your cars are breaking down in the middle of journeys and you are being called, it's not an easy thing. So having very good vehicles on the ground working for you is very key to a successful LMD. Thank you.
Thank you so much.
Thank you all so much for your active participation and contributions. On that note, we bring the curtain to a close on our presentations for this year's performance review. And that leads us straight into the most exciting part, which is the open forum. A lot has been shared, a lot has been heard, and we individually have great suggestions or ideas of how to navigate through the waters very well. We are faced with a lot of challenges, but we have the men and women here to bring the solutions on board. And so I'm very excited about this part. This is where we strategize and bring out all the possible solutions to our many, many, many problems. So on that note, I will hand over to the Director of Pharmaceutical Services, who will take us through the open forum to discuss key issues in our sector. Thank you. The floor is yours.
All right, so thank you so much, Dr. Edna, and good afternoon to us all.
Good afternoon, Director.
Yeah, good afternoon, Director.
Good afternoon, sir.
Good afternoon.
Comment all of
Good
us.
afternoon, sir.
Nice presentations and the wonderful suggestions that we've made to resolve the issue that confront us as a service. Like we indicated earlier, this open forum replaces on the program the general discussions and way forward. It is meant, amongst other things, to look for solutions to some of the key issues that we've identified during this performance review meeting. It will be recalled that on the first day, some colleagues began asking me questions. The answer I gave them was that they should hold on. That was the reason why we are here. So this very afternoon, let us use the next 20 to 30 minutes to brainstorm. We are currently 76 on the platform, and we're monitoring proceedings from here. Nobody should drop off, please, with all reverence. All right, so we'll begin by having a look at the key components of the pharmaceutical landscape in Ghana in terms of functions, interdependence. So this is going to guide our discussions. We'll look at issues that border on governance and management of pharmaceutical services, our resource production, financial sustainability, economic support, organization of services, and finally delivery of services. So this framework is what is going to guide our discussions going forward. And I will please urge us to exercise decorum in our submissions. We are not too sure who is listening, who has tuned in. We are a lot of senior colleagues who are listening to us. So please, in making our submissions, I would urge us to exercise decorum as much as we can. All right, so on that note, we move on to the first issue, which has to do with governance or management of pharmaceutical services. Dr. Hedido, in one or the other, made mention of this. In relation to the numerous government flagship programs being rolled out by the government. We are aware of the free primary health care, which will be launched very soon, possibly this month, I'm told. The Ghana Medical Trust Fund, that Amake 24-hour health service provision. We are all aware that as a service, we have to align with approved national policies. So the question we ask ourselves this very afternoon is that how do we align our activities to these flagship programs of the current administration? That is the first question that we're asking ourselves. We've also come to the realization that many colleagues don't really understand the policies and laws that govern the healthcare delivery system. So that matter, whenever they find themselves at the lower level, they get lost. They get bullied by other cadres, either administrators or accountants or other. They don't know the policies that govern the system. So the question we ask ourselves here too is that how do we enhance our knowledge of these policies and laws that govern the system? Because the system we are running or we are working with is a system of profound knowledge. And every system of profound knowledge requires a deep appreciation of the system in order to function very well. And the last thing I want to ask ourselves is that how do we link up with people who are politically connected to help move pharmaceutical services forward? Thank you very much. So the floor is now open. You can tackle any of this and answer. Thank you. So we have only 30 minutes. So let's allot maybe 5 minutes to each block or each discussion, each topic. Right.
Hello.
Oh, okay.
Yeah, Director, thank you very much for the opportunity. So on governance and management, I want to look at the second point, which is adequate knowledge on policies and laws governing the health services management that we all find ourselves in. And I think adequate knowledge only comes by us reading the policies or having them in the first place, or through trainings, but most often we just chance upon it. No, we know Ghana Health Service has a policy dissemination program, which even is part of our holistic assessment processes. But I think as pharmacists, we have our various platforms. We have our maybe chief pharmacist platform, regional gospel platforms, and everything. So these policies, apart from them being available maybe on the Ghana Health Service website, immediately they come out. If we could disseminate them also on our, with those who have real understanding of the policies, can add a bit of details onto it or to break it down so that anyone who chances on it on our platform and reads can familiarize themselves with these policies and also get themselves abreast on the happenings in the front lines. Sometimes, we have information asymmetry. Some category of staff just get the policies and they know the policies and the law, and they tend to use it to bully those who really don't have it. So I think making them available, and also like some recent developments in the pharmacy stores issues, realized that some laws were quoted and people took time to break them down so that those who read really got insight about what the laws were saying. I think if we can approach it that way, it will enhance our knowledge on the policies and laws governing the pharmacy profession as far as the health services is concerned. Thank you.
All right, thanks so much for that suggestion. We are very grateful to you, Chief Felix. All right. Government flagship programs. How do we align our services to these flagship programs?
Hello.
Yes. Please identify yourself. And
Yeah, this is George, WHO.
all right, George. Thank you.
Yeah, I was wondering whether I should speak or I should just listen. I think just to add up to what the first guy said, I think most of these government flagship programs, policies, and laws, yes, knowing them is okay, but I think the primary focus should be how do pharmacy fit in it, so that when we are measuring implementation or assessing the implementation of these policies and laws, pharmacy will not be left out. Like he mentioned this, what do you call it? The letter which came out about drug management and everything. Yes, the only thing that saved pharmacy was because it is in a public health law. If it had not been written in black and white, I mean, we would have been out of it. So how do we fit into some of these things, whether directly or indirectly? How do we contribute to the flash program? That is what we should be looking at, not just the knowledge of it. I just trying to add that. Thank you, everyone.
Thank you very much, Dr. Hedido. We are grateful. So how do we contribute to the development of these policies? All right. I recall very well during our AGM in Kumasi, KNUST, the WHO country rep made it clear to us that the most important thing is to be at the decision-making table when decision is being made. And that's very, very true. And some also told me that, look, if you are not at the decision-making table, it means you are the menu being discussed over there. So we have to make sure that we actually find ourselves at that decision-making table and make contributions in the development of those policies. So the next question we ask ourselves is, so how do we basically find our way there? How do we link up with the policy makers so that they can also make input when policies are being developed? I'm reliably informed that very soon the Ghana Health Service will call for the review of the Ghana Service Act or the development of an airline to implement the act. Whichever the situation is, it means that we must weave our way through the decision-making table so that we can make our inputs during the development of the airline or the new policy or new act, sorry. So how do we weave our way to the table? Can we discuss that? Because it's so dear to me. All right. Please identify yourself and talk and speak up.
Yeah, okay. Yeah, so thank you very much. This is Oyafi Manuel, Gospel Chair. Yeah, so Director, this issue, I think first and foremost, we are privileged to have very senior colleagues who are in places of policy, from headquarters at the Ministry of Health, then to the Ghana Health Service, and then the other allied agencies. I think from my little, experience working with the union, we will need to, first and foremost, we should be able to get information and then we act on it. Secondly, if we preempt a review of a policy or if there is a current policy in place, we as a service provider can set technical committees to review these policies, identify the gaps that there are in, and then look at where we can increase our hold on it. For instance, we should working together. Maybe the union, Ghana Health Service, MOH, the pharmaceutical sector, we should be able to review the Ghana Health Service Act and then look at areas where there are gaps in the provision of pharmaceutical services and then actually evaluate all the other service areas to possibly look at areas where we can increase our stake, so that as soon as we hear, I mean, the review actually being done, we can submit. I mean, we can submit our policy proposals based upon what we have, the work we have done. And so in that light, I believe the director can commission a technical team. The office can support. I think Gospel now, we can support some of these things so that we look at what will be in our best interest. And the issue is as simple as that. I mean, if you look at the other cadres, they simply consider what they can even skew to their advantage so that they will always have the upper hand. From looking at how even directors are appointed, medical superintendents to heads of agencies, etc. The whole law policy implementation is skewed to the advantage, and we should be able to look at such areas where we can also exploit to our advantage. On the government's flagship programs, I think free primary healthcare, first and foremost, the pharmaceutical front, we can make a statement available in as much as we are part of the healthcare provision space to let the government know that, yes, indeed, we are ready, we are trained, and we are available to, for our services, to render our services. And then I think I'm very much aware that the Mahama Cares program, I think they also want to look at training some particular staff in some of our colleagues in such areas. I'm aware about those that relate to cancer care, and I think there's also the push for colleagues who are in the space of the non-communicable diseases in renal, endocrine, and then cardiovascular care. So we can make available we should be able to make available colleagues so that they can specifically train. Our regional chiefs can specifically target specific numbers within their regions and then submit same to your office respectfully, Director, so that at least everything will be in sync, so that at the end of the day, we can be sure that we are training, specialists who are aligned in these specific areas and who have roles to play directly within the regions and then in the district. The last thing I will start on pertaining to this is also the factor of we making medications available. You know, most of the time we talk about the tracer medicines list, and we all know it's just a list of some, I think some 65 medicines or so, very few. But to be honest, we as pharmaceutical care providers should make sure that we have these medicines available when the public calls upon us. And I think maybe in the next aspect, we just have to make the medicines available. And that is one key way that we can also support the government flagship programs. Thank you, Director.
All right, thank you. I think because of time, we'll move on to the next one. So thanks so much for contributors, Gospel Chair, Dr. Hedido, and Chief Felix. The next one is resource production. And here we have in mind two types of resource. The first being human resource, and the second, of course, will be essential medicines or medicines. All right, so in relation to human resource, we realize that one of the key challenges that cuts across all regions is inadequate human resource. We realize that in Northeast, we had only 2 pharmacies, one in the public sector and one in child facility. So what do we do? What can we do to beef up the human resource that delivers pharmaceutical service? What is the most important human resource when it comes to service delivery? The next question we also ask ourselves is, how do we build capacity amongst us? It is said that lack of capacity and lack of confidence lie in the same bed. And capacity, we all know, is also not built overnight. It takes time to build capacity. What strategies can we put in place to build pharmaceutical workforce capacity? And the third is that what can we also do to ensure that we have as many specialist pharmacists as possible? The last time we had our senior managers meeting in Accra, the director of the Ghana College of Surgeons and Physicians was at that meeting. And he made it categorically clear that the goal of the College of Surgeons and Physicians is to have all doctors specialized. And they are working assiduously towards that. So taking a clue from that, it also means that all pharmacists should specialize. So how do we go around this very thing? Thank you. I await your responses, please.
Okay. iPhone, you can go ahead. Can unmute and talk. Thank you.
Yeah. Good afternoon. My name is Dr. Stephen Turi. I wanted to make a comment on the issue about human resource. Now, let us start from annual review. I was fortunate to be around when they did the Greater Accra Regional Health Director organize the annual performance review. So I realized that even when it comes to pharmacists, we weren't mentioned in terms of patient-pharmacist ratio. I realized that other cadres like the doctors, they mentioned one doctor, so how many patients to one doctor. They mentioned for the nurses, and they didn't mention for us. So I was then thinking, if we don't even know how many pharmacists we need per patient, how do we now even know the numbers we need to be able to say whether we are even inadequate? Is it like they say that advocacy without data is just an opinion? You tell somebody needs to, what shows that you need them? You see, so I was wondering why most of the time when we are even in such fora, we don't get pharmacists mentioned as to how many they need. They tell us all the time, bring the numbers you need. Yeah, you bring the numbers. It's just from your head. We are inadequate. That is it. But those powers that be in forum like that should be able to see it and know that really, if it's one pharmacist to 100 patients, and we are getting one pharmacist to 1,000, it is there for everybody to see on the PowerPoint. That's one area that I think that we need to start from. Advocating for our numbers on WhatsApp platforms, it doesn't end anywhere. Those who employers don't WhatsApp platform to see our numbers there. So I would suggest that in those little places, whether in the regional level, any little opportunity like this event we are having now, we can always advocate that. We are not adequate because we need to have, even the police, they say it, every other profession say one policeman to 1,000, this one, but I've never seen them. Another thing is, I learned that by the design of our work. We don't get, our chief pharmacist does not get to do a presentation because I think we are subdued onto clinical care also. So I realized that even the aspect of pharmacy practice is mostly done by another cadre for hours. So when you do that, we get most of our data onto the DIMS. If somebody by the click of a button can get the aspect of your job, then you become like a ceremonial person. You get it. So I don't know what we can do to make sure that the work we do is not just reduced to RUM. And what's the other thing? That's not the only thing we do. We do quite more than that. But it has become like now when you mention pharmacy, the next thing is RUM. And that's the end of it. But we all know we do more than that. Okay. So these are some of the things I think that we need to be looking at and making the necessary drawing the necessary polite attention for people to not just limit us to RUM. RUM, they are just figures. You calculate with this in a few seconds. Let's put it into the DIMS. We don't come to work to do that alone. You see. So it's one area I suggest that we will have to really if there's a redesigning of our, especially in the hospital sector, of the work we do, because if you come to the hospital, you see a doctor, just seeing the folders alone, they tell you he has done a lot of work. We do, when we write the report, I was telling our chief farmer, the report we write to rigid and then narrow it just to RUM is painful. You write a lot if you see the templates. And the only thing they tell that you are doing RUM. You get, and it's something that I think we'll have to look at that area too. You see, and then like the senior colleague was talking about, the Ghana College of Physicians said just, churning out a lot of specialists. You see, you get a specialist. Then the specialist is in, let's say, a polyclinic. What's he going to do? Maybe like, I think one of the colleagues was saying that he and another person are the only people of East. So you get a specialist in a small facility. What is he going to do there? So you end up realize that most of our people, unfortunately or whatever, do specialty because of salary. It's not about the output. So you see that mostly you go and see a specialist somewhere, and he's virtually doing the same thing like a pharmacist who just entered. Like sometimes we go on strike. They say we should lock the store, we should lock the other. When a doctor is going on strike, he doesn't lock any consulting room. He takes the knowledge away. Go and do it and let's see. Easy. But when we have to now lock places, no, we didn't go to school to lock in places. The knowledge is in the head. I've not seen a doctor locking in consulting room. If you can do it, go and do and let's see. And that is where we need to be aiming at. Getting the resource in the mind that they need you, not the circumstance, but they need you as a person. So when you are not there, your absence should be felt. They used to do that in Kolebu when Raymond Tete and Co were there, Koko and Co were there. They organize ward rounds, they don't see him, they have to wait. They do that at Confanoche. When Dr. Takra is not there, they wait until he comes to Confanoche before they do the ward rounds. So I think that's where we need to be aiming to reach. That they will value the person, not that we are just a conveyor belt. Is there para? There's no para. Okay, the pharmacist said there's no para. That's it. That's your relevance. And I think we are more than that. You see, we are not there to be telling them offhand whether we have chloroquine or when we used to call whether we have alimiatemdalufant or we have this. No. We do more than that. And I think that's the area that we are shortchanged, and the public or the people think that what they see us for is what we do, and that is it. But we know we do more than that. And I think that we need to look for strategies for that. Thank you.
Right. Thank you. Mention your name. Can you please mention your name?
Yeah, Dr. Stephen Ture.
Dr. Stephen
Ture.
All right. Please, where do you work?
Ashama Municipal Hospital.
Come again. Kaswa.
Ashama Municipal Hospital, yes.
Okay. Ashama Municipal Hospital. All right. So, yes, Doc, I think you've been brutally frank with us. You've been brutally frank with us, and we thank you so much for frankness.
Yes.
So happy.
Thank you, sir.
Raise a hand. So you are happy. Can you please speak up?
Yeah, talk about the mentorship, the capacity building. Hello? Hello?
We are listening. We can hear you, Happy. Please go ahead.
Hello?
Yes, we can hear you.
Yes. I want to talk about the capacity building.
Okay.
I think as a pharmacist, we need to encourage the new ones by mentoring them, especially at the places we work. Some of them, when they come, the mind they have is different. But as seniors or as managers, we need to put them along. Whatever we are doing, we need to teach them to understand and do beyond what they've learned from school. In doing that, we can also encourage them to continue schooling, do the specialties, so that at least the numbers that we have in the system will be great. Then they'll see the great work we are doing in our facility. Thank you.
All right, thanks so much. Happy. Any other contribution? Any other suggestion? All right.
Yes, Director.
All
My
right.
hand was up. I thought you were going to call me. And thank you very much. So, in pharmacy practice, I think the specialist pharmacist training gives us the opportunity to create a niche for ourselves and for us to be duly recognized and appreciated so that the demand will create the recruitment that we all desire to have the numbers so that we'll be able to perform to the standard, according to the standard of pharmacy practice, all the things that we need to do at the facility level. So whenever we are managing a case, okay, there's a suggestion. Whenever we are managing a case, for instance, a hypertensive case or a diabetic case, and the patient is in front of us, usually we tend to be in a hurry looking at the numbers that we need to serve the patients and the pressures, and just take this one and just we should take our time and spend time to optimize the therapy for the patients and also advise to improve their quality of life so that at the end of it all, the patient will appreciate the value that we are adding to the healthcare and onto their lives, and they will even demand for more of us. That is done in other countries, in the US and other places, where apart from the medication, you're hypertensive. So now how do you reduce stress? How do you exercise? How do you change your food? I mean, all those counseling points. We don't have to necessarily have a counseling room and a lot of time to do this. Excuse me, I have to just come to the doctors comparing. Usually I don't like doing it, but when we get to the consulting room, irrespective of the patients at the waiting, the doctor will take their time to clerk and prescribe and educate and do all those things before the next patient come in. So at the pharmacies, irrespective of the load and the pressure, if we can take time to really look at the disease condition and look at how we can enhance their health, optimizing the therapy and the medication effect that is ahead of us, I think it will go a long way to help in the numbers that will be demanded of us, and also the specialists that will come to bear. And maybe my last one is I think the reporting, the pharmaceutical service reporting, like we are doing, we should have a space where the clinical or specialist pharmacist activities will be documented in terms of numbers, where we can quantify or even qualitatively and can project that as specific or unique things that we are doing as a profession. I think it will help us a lot. Thank you.
Okay, Dr. Uso wants to add on. So Dr. Uso.
Thank you, Director, for the opportunity. I just wanted to add on to the point on the inadequate numbers. I mean, why some of these things happen. So I've realized that for the service. Yeah, hello. All right. So for the service, HR does employment using a certain standard tool called the workload indicator of staffing need method, which was developed by the WHO to determine the number of health workers required for a specific facility based on their actual workload. Okay. Right. I think we need to intentionally educate our workforce on some of these things, because even in our reporting, when you look at some of the numbers churning out, it indicates we are running a perfect system. There's no need for numbers. And when HR sees such a report, they wouldn't see the need to employ you. For instance, I'm just giving this as an example. I'm not targeting anybody. If you write in a report that you spend, let's say, 60 seconds in dispensing, it implies you are very efficient and you don't need any more staff to be employed. And they are also using the standard. It's a standard. And so I think we really need to get ourselves educated with some of these things. And like the previous speaker said, look, let's take our time so that our relevance will be felt. And let everybody know that we spend a lot of time in carrying out our task so that they will see the need to employ more of our colleagues. Thank you, Director.
All right. Thank you. All right. Chairman wants to talk because he's my chairman. I like
Okay, yeah. So, Director, this one, yeah, very short. Yeah, Director, is it possible? One thing that has been bothering me, when facilities need the services of anesthetists, even doctors, when they're on leave, etc., they easily employ locum staff to fill in. Is it possible that our regional chiefs and institutional head of pharmacies can be empowered so that in the absence of mainstream recruitment, etc., we can probably engage some of these staff also, either one on locum basis or on casual basis? Because one thing I've seen is that, in all honesty, all these standard operating procedures, we are very much aware. And I think no pharmacist would intentionally say refuse to really work as it's being put. But I think we need the numbers. And if the MOH is not giving financial clearance, let's kindly empower the heads of pharmacies and the regional chiefs to engage some locum so that at least we can fill in the gap, which will also at least increase, how efficient we work at the facility and then create that presence that we are craving for. I think that one can be a stopgap measure, even as we are also doing all the necessary advocacies for government to, give financial clearance for the recruitment of staff. Thank you.
All right, Chairman, thanks so much for that suggestion. I've seen Emmanuel Kweke raise the hand. So, Dr. Kweke, let's hear you.
Yeah, thank you very much for a wonderful program. Concerning the capacity building issue, I don't know. For now, I want to be corrected anyway. The number of specialties at the Ghana College are quite limited. I know of clinical pharmacy, public health pharmacy, and I don't know which one again. And besides that, like all the people going even there, they are all interested in clinical pharmacy. The other issue has to do with financing. If we want more people to enroll on the program, then it is done for the medics. If my memory serves me right, they say brain drain to curb it. So during President Kufuor's time, they established Ghana College of Physicians and Surgeons so that they could be trained locally. That was done. So they were going. They lobbied and asked for the tuition to be paid for them. It's being paid for them. They get steadily we pay. They still pay. Recently, one of my junior colleagues got admission to the college. He brought the admission letter. I took it to management. We were looking for support. But they said they couldn't do it. And I was like, so my message said, why don't you people also lobby so that government pay this money for you so that it become easier? Because if you leave it to the institutional level, a lot of them will not be able to do it. Even if they will do it, it will depend on the goodwill. So this was a comment he made. Unfortunately, I was so sad about it. He is doing it now. I encourage him to continue, but he has to pay from his own pocket. So these are some of the issues. So the expansion of that, we are talking about supply chain, the recent development in Greater Accra. And we were discussing if pharmacies have specialized supply chain, if somebody wants to infiltrate in that, we will say, we also have specialists in that area. But for now, I don't know whether that supply chain thing is even a specialty in the Ghana College. The medics are very good at that. They look at the focus, the future, and they develop program. So, and encourage their people to go and train in that so that they can, when opportunity comes, they grab it. Now here they are doing a lab something. Recently, if your memories serve us right, they wanted to take out the labs. The biomedical scientists made a lot of aluta. Now they are training their people. The next move will be that they have also been trained in biomedical science in addition to medicine, so they can better manage the lab. So let's all be strategic and then look at the future. What are the gray areas that are coming up that we can either encourage the college to develop programs for the young ones to take advantage, because the clinical pharmacy alone is not enough. There's a lot of diversification that we need to do, because not everybody who is interested in the clinical pharmacy. Some who are even there is just by default. They found themselves in the hospital. So we should have an array of programs of specialization, and then it's well marketed for the young ones to develop interest in it and go and do. Then we'll be increasing our base, even policy, what do you call it, public health. We're talking about any time government bringing any policy or law. We don't have a lot of our people in that area who even be nosing around, say, oh, this is coming up. Let's strategize to grab it. What do? We don't have a lot of our people in those spaces. So sometimes the thing is implemented before we realize that we have been left out. Then we are now firefighting. So I would encourage that we should be more strategic in this specialization area. It shouldn't just be clinical pharmacy alone. Thank you very much.
Thanks so much, Zakweke. So we should be more strategic in our specialization. That's great. Let's move on to the next. B, the area of medicines management. I don't want to say commodities management, medicines management. In our submissions, it came to the fore that we have acute shortage of medicines across the entire country. I think only 18 regions were doing well. So, how do we ensure that medicines are available to the population? Because that is one of the key things the whole world is looking up to us to execute. When there are no medicines in the facility, the first person who will be questioned is the pharmacist. Apart from that too, how do we enhance pharmaceutical logistics management in relation to selection, forecasting, quantification, and supply planning? Somebody alluded to. Gill mix utilization. How do we leverage on that to project the image of pharmaceutical services? Because I know that most of the inputs that were made in developing Gill mix came from pharmacists. All right, so let's deliberate on these few issues and see the way forward, George. All right. So, Dr. George, you want to contribute? The floor is open. Thank you.
Sorry. I think my contribution was to the previous, but we will move forward. That's why. Just to say that with the specialties, I think Antimata was online from the college. Maybe she could throw some light. And also just to add that we need to venture into other areas which are not traditional to us, like the expanded program on immunity, the program areas. Once we are relevant over there, we can also go and make noise. We cannot be one man showing like those two people then is doing everything. Once you are producing and doing everything, they will not see that you need more people. That's just something. But Antimata can talk about the college issues. Thank you, Nova.
So, Chief Ellis, your hands is up.
Yes, Director. I want to also comment on this one too.
I'll play with you.
Medicine.
Let's be a bit snappy. Look as if. So let's make
okay. So yes, Director. I think medicine management is a technical area that we also need a lot of pharmacists to look at it with interest and specialize or get additional qualification in supply chain management, especially so that we can strategically position ourselves in the regional medical store settings where really pharmacists have been the heads over, but in recent times we are seeing other cadres coming in. So in regions where we don't have pharmacists not having supply chain qualification, maybe a certificate or a master's or a PhD or something in supply chain, or those who are at the medical store to have this, so that we can strategically have the numbers to position ourselves there before we lose this traditional position that we've been holding over the years. Thank you, Director.
Emmanuel.
Yes, thank you, Director, and for this opportunity once again. I think yesterday I raised this issue about the medical stores management and general logistics management in even the hospitals, and the issue about the letter that came up from the Greater Accra region. I feel that strategically, if we take charge of RMS, then we are good to go. Because as we speak now, I was even having a discussion on the side about our role as the key signatory, the chief pharmacist being the key signatory to the medicines account at the RMSs. Meanwhile, when it comes to the total management of RMSs, it's under the unit of the Department of Health. So if we are able to take up this responsibility and then make a case, because as we speak, the RMSs are all thriving on or surviving on the medicines that they procure and then manage, which is largely managed by the pharmacists. And I've been saying that if we are able to make the RMSs solely medicine stores, at the end of the day, it comes to us, because when you go to the RMSs, the non-drug consumables that are being managed there, and looking at the way how much is brought on board, it's largely medicines. So why should that area be headed, or if you like, managed by a non-pharmacist? And as Farm Felix rightly mentioned, we should make sure that we position ourselves very well, that we take up this mandate. If we can ensure that the non-drug section is shifted from the RMSs that we have, then we can take over. And then with specialization too, I think we can ensure that medicines will always be available and then properly managed by us pharmacists. Thank you, Anova.
All right, thank you, Emmanuel. Emmanuel Kweke, you want to add on? Okay. Okay, let's move on to the next one.
Hello. I think concerning the medicine availability. Hello.
Please go ahead. Ima, please go ahead.
Yes. One of the albatross on our head is this framework contracting thing. Because if you look at it, more often than other items on the framework contracting are the traditional things that ordinarily anybody coming to the hospital who need medication will take one or two away. Unfortunately, when this concept was born, some of us were so excited about it. One, it's going to take up the burden of we individual facilities looking for this item. Secondly, they are going to procure in large quantity, and they'll ride on economy of scale, and they'll be cheaper to the consumer. Unfortunately, these two, aims of the program, so far, we've been into it for so many years now, but we are not realizing it. And I don't know what we are not doing right. And this is affecting medicine availability. greatly in the facilities. And like you rightly said, when those medicines are not around, I mean, every opportunity I have, I educate our staff. Now, it's not that the pharmacist is not doing anything about it. Unfortunately, when you ask for non-availability for these items, the regional chief pharmacists are not ready to even give you, because they're also afraid. Because somebody once, I understand, made a comment, politician, everybody jokes, he'll be dealt with. So sometimes the truth is that our facilities, sometimes auditors came and they were querying us that we didn't have any. And we said framework contract. I said, no, what is framework contracting? Imagine somebody is in labor at night and you don't have oxytocin. And you say framework contracting. So you're saying that no, we are professional in the first place. So if those policies are not helping and we sit down, they were really surprised. So it's one of the basic things that if the framework contracting items can be improved, because they are the ones we consume. Even when it comes to insurance, the insurance people, when they come, they are the ones, the drugs that they take in large quantities. So when it's not available, it really shows our, what do you call it? For want of better words, as if we are not doing our work. But it is not. The policy has tied our hands in some way. And it's about time, if it's not working, policies are made for man, not man for policy. It should be scrapped so that we, if they are not available, when the free work contract was, every facility move around and then get the medicine in good time and restock, so that we don't have these long hours of days of stockouts. I remember 2 years ago, common paracetamol, clients were insulting us. That, what are you sitting here? Common paracetamol tablet you don't have. Then what is your use here? When you explain to them, they don't understand. So the framework contract is about time. I don't know where the idea came from. If it's not working, we scrap it.
Yes,
We want it to work.
We should review the
Let's
benefiters.
Sorry?
Yes,
we should review the policy.
Benefiters. Point well made. Thank you very much, Mr. Kwek.
Okay.
Okay.
All right, thank you.
Daniel Appel, please be snappy with your comment. Thank you.
All right, thank you very much, Director and team. Beautiful presentations, and we love the show. Now, I want to comment on Gilmist utilization and tie that to pharmacists accepting postings to. Hello, can I be heard?
Yes, you can be heard.
Loud and clear.
You can go ahead.
All right, okay, thank you. So, as Director rightly said, initiation, when we started Gilmist, it's all about pharmacists. We're there throughout. But unfortunately, pharmacists, I think they are becoming comfortable in their small zone. They don't want to push themselves small and own it. And that is a problem for us. So I'm thinking, for the sake of the profession, at times, there are certain things we have to jealously guard, to own it. And when we do that, they will be calling on us for the success of this. But unfortunately, the facility level pharmacists are not interested at all. So I don't know. And that I want to tie that in the pharmacists making themselves available at the remote parts. Look, doctors are moving here and there, they are all over. But yes, in incentives and things play a part, for which I think the direction the director should help out of that. Pharmacists should also be prepared to move out there. Look, move to the periphery and sacrifice small for the profession. Until we do some of these things, it will be very, 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 very difficult to want to achieve this. So let us move out of our comfort zone small for the sake of the profession and try to build a profession for those coming to also emulate. Else, we have a long way to go. Thank you.
All right, thanks so much, Daniel Appel, for that contribution. You are most appreciative. We move on to the third block, which is economic support. We realize that for most regions, we have terrible challenges with moving drugs family, but it keeps on dwindling each passing year for several reasons. So and one of the things that also came to the fore during this was the fact that the indebtedness at the health centers and the CHIPS compounds to the regional medical store keeps on soaring each passing year. How do we improve upon our debt recovery activity at the regional level? How do we also ensure that the revolving drugs funds is prudently managed at all levels in the service? Thank you. All right. We are still waiting to hear. We are still waiting to hear contributions from the floor. If people don't talk, I'll start mentioning names. All right. So who is prepared to contribute to this very discussion?
I'm mentioning names.
In the floor.
Hello, Director.
Okay.
Yes,
look.
my
Okay.
what to?
Chief Rita Ashanti, can we hear you?
Yes,
All right.
I want to talk about the district pharmacist concept.
We'll get there, please. You're not there.
No, in connection with the dwindling RDF, I want us to push that agenda to the point where we have that pharmacy signatory, that mandatory pharmacy signatory at the district level. There's a lot of abuse of the RDF at the district level. Some of the districts, they don't even have any recognized medicine account and a non-medicine account. The two are together and they are being spent. So I wish that we push that agenda forward where, though we are not there yet, district pharmacists become a recognized force at the district where they are also mandatory signatories to the medicine account. They're responsible for their NHIA reimbursements, reaccreditations, and all. That is the bit I want to mention so far as the RDF management at the DHS are concerned. Thank you very much.
All right, that's well spoken. Thanks so much, Chief Rita. All right.
Hello.
Chief Felix.
Director.
All right.
Yes. Thank you very much. I think Chief Rita just nailed the nail right on the head. The issue at the lower level is competency, capacity. And when you get there, some few monitorings that I've made, you go to the CHIPS area, you get maybe a community health nurse, a midwife there, how the medicines are being managed. You want records you not even get in the first place. Then secondly, when at the district level, when the NHIS money comes, how it is transferred even to the revolving drug account before it is spent. The money is just sits in one, NHIS is not dividing the money. If we could get them to really write two separate checks, it will cure a lot of things. That's the first point. The second thing is, once the money gets there, how it will be separated into drugs and non-drugs for the drug parts to be used to defray drug costs. It's a huge challenge. And our auditors haven't helped us as it is. So the money gets there, it sits in the service account, it's spent, and the bills keep rising up. And the sad part, I will cite my personal example I had in Hafu, Kenya, where the health center wasn't having medicine, and the town decided to demonstrate that against, they don't have even common paracetamol and all that. When we went into it and realized that medical store wasn't able to supply them of these things, and we're asking even the DHA to put in a system to procure even for the facility, they could not. Though they, at the district level, we think they can even procure for the health center, they could not. And they were just solely relying on the medical stores. However, if the drugs are not there, then it leads to a whole lot of things. So, Director, please, if the auditing system can ensure that the amount that is paid into the district is transferred to the revolving drug account, it will help. If NHIS is able to even write 2 checks separating the drug from non-drug, it will help. And if we get a cadre of people like Auntie Rita just said, who will be there to ensure that the right thing is done at that level, it will help. Other than that, it's like pouring water into a basket, excuse me my word. And this is the way we are going now. And it's a headache to me. Thank you very much.
Thank you. It's 3:41. I will crave your indulgence to shorten our contribution. So let us by 4 o'clock, we should be out of this place. We are still monitoring participants on the platform. We are 75. All right. So I will commend all of us for the good that we are doing. Let's finish up. We move on to the 4th one, which is organization of services. Chief Rita spoke about reintroduction of the district pharmacist concept, or revisiting the district pharmacist concept. One of the issues to the how do we restructure pharmaceutical services at headquarters, at the regional level, at the districts, and at the hospitals to enhance visibility and improve service delivery. Is this still online?
Director.
Daddy.
Hello, Director.
Yes. Are you online?
Yeah.
Okay, please.
Director, this is Chipoku.
Okay, Chipoku, after which you speak.
Yeah, concerning the restructuring of pharmaceutical services, I want to know if it is feasible at the regional level, if the chief pharmacist can be put under the office of the regional director to enhance our work, so said that when public health is moving, we can move with them as well as the clinical care. But what I see over here at the clinical care is purely personal issues. If he likes you, work with you. If not, so that is my challenge. Thank you very much.
Thank you. Well noted. Please, Nee, Director says he should speak up.
Yes, thank you. So, Director, I'll touch on the supervision of the lower level facilities by pharmacists. For OT region in the past, what our regional director did was that he made supportive supervision one of the appraisal objectives for medical superintendents. So each quarter he expects you to visit at least one health center, when supervision, write and then submit a report. So for the year, you do about 4 different health centers. And when our medical superintendents were doing that, they will typically move with their pharmacists, move with their chief nursing officers, sometimes move with a midwife, depending on the issues they want to go and talk about. And when we get there as pharmacists, we take the opportunity and also go through all the issues concerning pharmaceutical service. It actually helped with the supportive supervision, providing some capacity building for the lower level facilities, because we simply don't have the numbers to do the job. With time, that objective, appraisal objective, is not there again. So it's basically gone back a bit, because it's becoming a bit expensive and tiring for the pharmacist to do that by himself. The districts don't have money to always support you to do that. So perhaps if we could institutionalize that, where it becomes an appraisal objective for medical soups, we actually hang on. We go with a hospital vehicle, it's fully funded. We do the supportive supervision, and then it's able to solve some of the problems at the lower level. Thank you.
Dr. Setu, I've not heard your voice, senior specialist at Tua Government Hospital en route to Upper West as the regional head of pharmaceutical services. Can we hear your voice? Set to speak up. Want to hear from Solomon Obri, the RMS manager for AC Regional Medical Store, who has been reassigned as the head of pharmaceutical services for Central Region.
Hello, Director. Good afternoon, senior colleagues. Director, I thought this is an orientation for some of us. So, I mean, listening to experienced and seasoned chief pharmacists has really been very helpful. But maybe just to comment on the challenges at the sub-district level with respect to logistics and financial management. It cut across all the regions, and Eastern is not left out. The main challenge has been that the district's oversight of these facilities hasn't been very efficient. So the district interest has been with only the finances that comes out from these facilities. And they do not pay much attention to the operational efficiency and the internal controls, at these facilities. So you have these health centers and chiefs managers needing basic things to function effectively, and the districts, do not make them available. These lower level facilities, they don't have financial visibility. They work so hard and they don't see how much money they are making, So this normally would also lead them to commit some, more practices for them to also, sustain the system that they are running. So for instance, you go there, they have cash and carry, they will not receipt it, they'll pocket the money, and they use some of these monies to actually run these facilities. But of course, they do not account for all of them. Knowing these problems, what we decided to do in Eastern Region is that we noticed that there was a clause in the accounting, treasury, and the financial rules and regulations that made provision for some health centers to be declared as large and autonomous. And in this case, these health centers would have some level of independence in managing their finances and also managing their logistics. So we activated that and then piloted just about 20% of facilities of health centers. So these were declared as large and autonomous. And by this, they were supposed to manage their own finances. They were supposed to sign their own checks. Of course, they will have some relationship with the district health administration, but they maintain control of their finances and their logistics. After implementing this project for about 2 years, the data clearly shows that the 20% of health centers which were declared autonomous, they have reduced their indebtedness. They've been able to improve on their availability. Even government's utilization has gone up. In fact, we made a presentation at the just ended annual performance review, and it provides a classical case for expansion of the number of autonomous health centers in the region. So that is one way to look at it. But from the pharmaceutical perspective, I think that we should also be looking at having enough dispensing technicians, to man these autonomous health centers. Because even in the current states, it is just the physician assistants and the accountants and the district director who are signatories. But because the physician assistant see himself as accountable, he police the system, diligently, and make sure that he's able to account for whatever resources that he has been given. So we can leverage on this, get enough dispensing technicians to at least manage the medicine, parts of this whole thing. And I believe that it will be very helpful to our sector. Thank you very much.
All right, thanks so much, Dr. Solomon Obri. The fact that it's an orientation doesn't mean that you can't speak up. You can. So thank you so much for the wonderful contribution you have made. Justice, can we please hear you? Justice.
Yes, Director.
Yes, sir.
Yeah, Director, thank you for thanks for the opportunity. I want to take a bite on the issue at hand. Chief Rita rightly mentioned about the issue of district pharmacist concept, which some of us will wholeheartedly support. And I want to use myself as an example. I remember some years ago, 2013, 2014, thereabout, I was at Central Gonja DHA. In fact, that was the first time the district was getting a pharmacist. Unfortunately, we had no hospital, so I was forced or compelled to be at the DHA. But then I realized we had a district medical stores. That was the time the district medical store concept was just about fading off. So we had a district medical stores, and almost all the health center chiefs compound were receiving their commodities directly from the district medical stores. So whenever NHI made reimbursement, it would pass through an account at a DHA before a check would be issued to the regional medical stores. So I took advantage of that and insisted that I should be made a signatory to the account, the drug account, which was granted. Now, what happened was that anytime NHI made a reimbursement, then I will call for the bank statement from the accountant, and I'll do my reconciliation, write the memos, and then get the approval of the district director, and then the checks will be signed to the RMS. At that time, really, things were okay. We never had problem with health centers and the chiefs compound owing RMH to the extent that we are having today. So like I said, that idea is a very laudable one, and we must push it to its logical conclusion. Now, the other issue I want to say is has to do with the realignment of pharmacists, the chief pharmacist to the office of the regional health director. I think somewhere last year or so, no, that was a year before, the grapevine out there was that chief pharmacists were going to be realigned to the office of the regional director. That was during the era of the former Ghana Health Service Council and then the former Director General. What have come out of that? Because as we speak, like Chief Poku rightly said, at the directorate level, it is only when they like that they involve you as a pharmacist, because most of the activities there are public health activities. But here's the case: we have been assigned to the clinical care. Clinical care, I mean, the deputy director of clinical care himself is no senator. Most of the time, they complain bitterly about being left out and all that. So the few opportunities that come their way, they don't see you as being. In fact, sometimes I even get lost as to whether we belong to clinical care or belong to public health or whatever, because some will be like, well, these are clinical things, forgetting that everything about pharmacy is also clinical. So I need to get clarity on that, Director. And then my last point, I want to revisit the issue of Gilmes. When I was at the hospital, I used to do so well with Gilmes. Until later on, I realized somebody else elsewhere was taking all the glory. So it actually demoralized me. And that brings me to the issue that Apau made. What happened when the issue of Gilmes and then the other supply chain reforms were being made? What was the input of pharmacists? Is it that we were not interested or what? Because the administrator will tell you that it's part of the support service. And everything about support service falls within administration. So sometimes I get a feeling that I can't be breaking my back day and night only for the glory to be given to somebody. And I believe these things are some of the issues that are making some of our officers down there, show that kind of lukewarm attitude towards Gilmes issues. So I want us to take a look at and then find out whether there's any way we can, get our way back into the Gilmes so that we can owe it. Because if you leave it with the administrators and then I didn't want to mention their name anyway, but I have to. If you live with the administrators and the supply officers, you realize that, and I believe that the main reason why in most of the regions, the Gilmes utilization is not doing so well. But the moment pharmacists take over this, then trust me, you see the changes. Thank you, Director, and over.
All right, thanks so much. Thanks so much, Director Derry, for that nice submission. We are very appreciative to you. So we come to the last one, which is service delivery. And for me, the focus now is on clinical pharmacy activities. How do we institutionalize what pharmacy practice? It is captured in our strategic plan, as well as our operational strategy for 2026-2030. How do we go about this? How do we enhance reporting on medication error, ADRs, and the like? How do we also institutionalize antimicrobial stewardship at all levels in the service? How do we embark upon point prevalence survey at least for now, all regional and district hospitals? And how do we enhance data management of pharmaceutical services? So let's discuss this issue one by one. We have only like 3 minutes left. We have only 3 minutes left. So please let me snappy. Thank you. And let's go point by point.
Can I come in?
Come in, please. Let me snappy. One or two seconds.
For the institutionalization of the word pharmacy, I think we should do well. We should update ourselves as far as the medical issues are concerned. Because now the medical doctors are learning. And we should empower our people to go on ward rounds. The chiefs should make sure our people go on ward rounds. Most of the times I do ward rounds myself because perchance I have done some special. If you go, you see that our head of pharmacists are not doing it. They are not going. Simple things. You go there, you see they are prescribing, allergic dermatitis with, they are giving antibiotics for allergic dermatitis. And pharmacists are sitting down. I saw that one of the pharmacies, and I saw that what they are giving for heart failure, presumed heart failure, wasn't the right drugs to be given. So please, if we don't support our pharmacists to go on ward round, in fact, it will be something else. So we should encourage them. We have MDs, we have specialties, they should do their job for us. And they should educate the rest of us to do same. Thank you very much, Director. Hello. Hello.
Medication errors and the like. All right. So how do we enhance reporting of medication errors, ADRs? How do we improve upon our pharmacovigilance activities? Because you agree with me that one of the key challenges that went through all our presentations in most regions is underreporting of medication errors and ADRs. How do we enhance that as a service? Because the whole world is looking up to us. We've got our medication, issues border medication. The whole world is looking up to us.
Hello, Director. Can I come in once again?
Come in, please.
Yeah, concerning the reporting medication errors, what we are doing at Bono is that we have a notebook that anything untoward is documented, and the heads of pharmacies are going through it. So if we can bring that one to play, where we have a notebook solely for that, and every month we look at the number of them that we've done. That's what we are doing over here. Thank you.
All right. Daniel Paul.
Director. Yes, I wanted to touch on the report on the medication error. I think a lot can be done. We want to place pharmacy where it is readily recognized. People must recognize our presence. And these are the things we begin with. So you are at the facility, all these are happening, and you're not recording, then we have a problem. So visibility, placing pharmacy at the top there, maybe in orienting pharmacists we post at the facilities, maybe the chief pharmacist will want to take this responsibility, orient them on what is expected of them, and this must be put at top there. They should report the error, what kind of error, what came out of it, and when we have the DTC very working, these can be presented. They can be presented. In fact, my experience at Zabsbu Hospital is some of these things, and over 10 years now, nurses from Zabsbu, when they come to Tamale, they want to look for me. Because you don't let this thing go, they must recognize your presence as a pharmacist through some of these things. So we are begging our chiefs to help the new ones come in before they go there. All these things are explained clearly to them, and on a monthly basis, they report to the regional chiefs on these things that they are doing, so that at least we can start from there and make ourselves visible when it comes to reporting of medication errors. Thank you.
Thank you, Mr. Kweku Daniel Apau, for that contribution. Okay, Bob Hayford, can we hear from you?
Thank you very much, Director, for the opportunity. Please, concerning the medication errors, I think it's very laudable and it's something that is affecting us. And we believe that if, like, we start our quarterly review meetings, maybe in personal meetings with the chief pharmacist at the regional level. I think our chief pharmacist, Mr. Pinton, was plan something like that. Say that we invite the medical officers, and then if possible, we start from medical officers to other cadres like the PAs. We invite them to pharmacy, maybe pharmacy review meetings, where even NHIS, because NHIS deductions, adjustment, they give us reports. So we pick those reports and then we discuss them to let them know the effect of medication errors, because it can even be, it even reduces what we call a cost on us out of the deductions. And then with the medication error, the diagnosis errors even can be a medical legal issue against you, the prescriber, who has done that mistake. One of his presentations to us at one of our regional Zoom meetings, that we were going to do some of those things and then invite those cadres. So I believe that if we implement such agenda and then do it in person at the regional level, inviting these prescribers to our pharmacy quarterly review meetings, it will also help to reduce the errors. Thank you very much.
Bob, I agree with you that medical have a lot of medical legal implications, and that's very all right. So I've seen Chief Ellis. Chief Ellis.
Yes, Director. I'll be very brief. Yes,
right.
Director. About advert drug reporting on medication errors, antimicrobial stewardship, and all these points, prevalence studies. We need refresher trainings on these. And these refreshers should be very practical. That demonstrate how we can capture them and report them. When I look at some reports submitted from institutions and we realize lack of adequate expertise in these things. So in one of these fora, like we are doing now, maybe an online something, you can slate it maybe a half year or something, maybe a refresher, then maybe practically and simple, somebody just runs us through, then we update ourselves for the current practices and it becomes easier for people to capture and report. Thank you very much.
For your contribution. All right. So when prevalence survey, I know some regional hospitals are conducting it on annual, some even do it twice a year. How do we leverage on that exercise and extend it to other regional hospitals and district hospitals? Well, it's also so important. For me, we should go beyond conducting REM survey and then complement those survey that we do with point prevalence survey as well. So how do we leverage on that? How do we extend, how do we scale it up to the other regional hospitals and district hospitals? Is anybody from Eastern Regional Hospital online? the head of Eastern Regional Hospital. Is she online? Yendi Municipal Hospital. Is he online? Upper West Regional Hospital. Head of Pharmacy, Upper West Regional Hospital. Upper East Regional Hospital.
Please. Doc, I'm around.
Please, who? Is that Ekwam?
Doc, please, I said Upper West is around.
Upper West. All right. Mr. Ekwam.
Yes, please, I'm around. Yeah.
I'm head of West today.
Yeah.
All right. So I want to know, are you
I'm around.
You conduct PPS every 6 months, isn't it?
Yes. Yes, please.
All right. Possible to scale up PPS to the other regional hospitals, other regional and district hospitals. What are your take on that?
I believe my current chief pharmacist made a comment on that. With the PPS is more or less a component of the antimicrobial stewardship program. So for hospitals to actually run it, they have to undergo some kind of training, practical training mixed with the theory, so that they will understand the whole concept of the AMS and what should be done. Because the PPS is very intensive survey, very, very intensive one, because it covers every ward. We can do outpatient, we can do inpatient, but currently is the inpatient that is being done. And it has to cover all the various wards of admission with the tool that you use to collect the data. And so it is intensive, of which we do it practically, so that you get a hospital. If you are going to put people together, you get a hospital, we have a data, we look at how we will generate the data. How we do the whole thing, and even PowerPoint prevalence survey, projects by doing just sensitization. So that is why yesterday Chief Opare said that doing our training on the guidelines, pharmaceutical standard operating guidelines, somewhere October, November 2024, I did a presentation with him, and one of the slot was on AMS, on antimicrobial stewardship, that he made me to give them a little bit of information, overview of that. And that is what he said yesterday, that it even helped us to reduce our antibiotic consumption in the utilization in the region. So I think it can be done, and it's easy to be done, but we need to have a practical orientation or capacity building for the pharmacist to take it up. And also, because it is not you alone that is going to do it, it's about antimicrobial stewardship teams. All of them need to come on board, like what we have done. We have the various ward in charges and their deputies and other supervisors, nurses who are supposed to get involved. So it is a broader perspective where we bring all of them on board. And that is what, for us at the Upper West Regional Hospital, it has been successful, because we have involved, apart from the main AMS committee members, we have involved all the various units, including lab, radiology, and all those things, to be part of the team, so that when we are moving to take the data, it is holistic. Everybody understands the concept. And also, what I could say is that if we do the practical this thing, it should be part of your hospital budget. We have been able to do it for getting to 2 years, because fortunately I'm part of the management and I'm part of the budget plans and budget committee I'm part of it. So I make sure that all our action plans and our budget for the coming year, by November, I make sure that it is being captured in the hospital plans and budget. So all DTC activities and all AMS activities program are captured, budgeted for, and it is part of the holistic hospital plans and budget submitted to regional director for approval. So when you are doing any program, it is being budgeted for, and everybody is aware of it. And the second aspect is that when you do these things, you don't need to shield it and let it be only at your pharmacy. What really helped us is that after we did this survey and we disseminated it, because all the hospital management members were involved, we disseminated it during our clinical meeting. It was even adopted to be the theme for our annual review for 2025, beginning of 2025 for the 2024. So I need to present the whole dissemination again during the annual review, because they saw a new concept that was coming up. And that is the same thing with the rational use of medicines, because of how we have been able to do it over the years. So I think that the most important thing is that we should do the practical training. We should involve the various hospital management on board. We should involve all the various walls and the units, because it's not only one area we do antimicrobial stewardship. It is in various areas, and it must be budgeted for. And one key thing is that the pharmacists are the ones who need to lead it. If you don't have a very strong pharmacist to lead it, then it will collapse. Nobody will really rally against anything on antimicrobial stewardship or DTC activity. And the good thing is that I'm the coordinator for both the DTC and the AMS. So it makes the work very easy. So thank you very much, Director.
Thank you, Daniel, for that detailed presentation. We are proud of you for being the coordinator of the AMS activity in your regional hospital. I've been there before, and I really appreciate the work that you are doing up there. We are proud of you. So what we want to say is that we are very grateful to all of us for sitting through. At the beginning, we were 75. We are monitoring participation, and as of now, we have a 76. So we've been increased. It means that it be 77, and that is great. So I'll hand over. What we've done is that all the discussions or all the suggestions that we have made, we have noted everything. And then I'll hand over to Dr. Edna to tell us what we are going to do further. We have discussed. Thank you.
Thank you, Director. Okay, so based on the discussions we've just had, we would like to move forward, and we want to take action as quickly as possible. What we intend doing is to set up teams of experts. We had 5 areas that we have discussed, and the suggestions have been noted, but we think that if we put up a team to lead it out and make sure that it's not just talk, we are walking the talk, it will really help. So we'll be constituting teams of skill set experts to manage all these broad areas we have spoken about. We will be doing this virtually for now. Where it becomes necessary, we will meet in person. So the office will be setting up these teams, and the links will be shared on our platform, the Chief's platform, and then the Senior Managers platform. For now, we will entreat you where you think you have expertise and you have much interest in, we will employ you to join so that we can walk the talk. A lot of times we talk, but we don't take action. This time we want to take actions. So we will end this here. The teams, the links for the various teams will be shared latest by close of tomorrow. And please join where you think you have expertise and your input will be much felt. So on that note, we want to really appreciate all of you staying all the way from morning till past 4, and even yesterday. We don't take it for granted. We really, really appreciate your inputs and your full participation. And so on that note, we will want to please hold on for me for director to come and give his closing remarks. But we want to acknowledge all of you for staying on till 4:16. We don't take it for granted at all. Just a minute, director had to step out. Please don't drop. Let director come and give his closing remarks, and then you can drop. Well, I think I have director's permission to close the meeting because he's indisposed currently. So on that note, shall we pray? Shall we have the closing prayer? Our Father in heaven, we are most grateful to you for making this a success, a great success. We thank you for all the participants, all our chiefs who were able to give their presentation. Thank you for everything that we have discussed here as managers and leaders of the pharmaceutical services. We pray that you continue to inspire us, give us great ideas so that we can really shape the practice of pharmacy in Ghana, and we can help our people in very tangible and impactful ways. We are grateful for this day and for bringing us this far. In the mighty name of Jesus, we have prayed. Amen. Please, director is here, so hold on.
All right. So, colleagues, on behalf of the Director General of Ghana Health Service, I want to express my heartfelt appreciation and gratitude for all of us for the good work done. We are proud of you. And like we all said, pharmacy has gotten to a point where everybody should put his shoulder on the wheel to move it forward. We thank you for all the good things that you are doing in the regions, in your districts, and at all levels. And we pray that the good Lord continue to strengthen you to deliver effectively on your mandate. Let me also use this platform to thank all senior colleagues who joined us, Dr. Tansa Matarito for sitting throughout the program, Dr. Hedida from WHO, my former regional director, Dr. Abdullah Bukari, and all senior colleagues who took part in this meeting. To my revered chiefs, God richly bless you. And to my heads of pharmacists at the regional hospitals and district hospitals and RMS managers, you are the third generation of pharmacy leaders. Those are the regional medical stores, those are the regional hospitals. So this meeting is meant, amongst other things, to identify the potentials amongst you so that we can add on you on as the next line of pharmacy leaders going forward. Thank you very much, and God bless us all. Thank you.
Thank you. Have a good evening.